Hello and welcome all to the 2023 ML4H, the Machine Learning for Health Symposium. My name is Harrer. I'm one of the general chairs along with Tom Hudson. And both of us are so glad that you can join us today for a full day of scientific discussions on how to improve human health through machine learning. We have a lot planned for you today, but before we get there, I just wanted to give a little backstory of ML4H. As some of you here would know, we started as a workshop as part of NeurIPS back in 2016. And as the community grew, ML4H became a standalone symposium, and this year marks the third annual edition of the symposium. Okay, so ML4H is hosted by the Association for Health, Learning and Inference, or ALI for short. ALI is a non-profit organization dedicated to accelerating machine learning to improve human health. They do this by supporting research, data, tools, education, and foremost by building community like today. We'll probably hear a bit more about ALI's activities in the afternoon session as we go forward. Okay, today, so we have keynote speakers that are spanning around the two themes for today. On the left, we have the set of speakers in the morning session who will talk to us about global health and health equity and how machine learning can help us address challenges there. In the afternoon session, we'll be hearing about generative AI and the ongoing advancements relationship to health. After the talks, we'll have some time for Q&A in the panel discussion, so I look forward to your questions there. I want to take a minute to thank our sponsors listed here. So Google, who is our premier sponsor, Generative, Optum, Microsoft, SageMaker Networks, Jensen, Google DeepMind, Stanford Medicine. I really appreciate their support to the Machine Learning for Health Symposium. Their support enables us to broaden our mentorship as well as the travel award programs. So thank you. Okay, so one of the sessions that I am looking forward to most today are the research roundtables in the afternoon. So we have 11 of those spanning across the different topics that are emerging sets of discussions in the field. And these will be chaired by senior and junior chairs who are experts in those areas. You can find more details on our schedule page on our website. New this year is the demo track. So we have a set of 6 demos, which are real-world deployments of machine learning systems in different clinical areas, as well as a new data set that is going to be announced today. So I'm very much looking forward to going through the demos that will be in the poster session. Okay, as for the submission stats, the thing that gives me a lot of joy is that our community continues to grow. So we had a record number of submissions this year, out of which we could accept 39 papers as part of our proceedings, which has been published as part of EMLR, and around 71 submissions that have been accepted as findings. All of these will be highlighted as posters during the day, and some of these we will get to hear from the authors as part of lightning talks. And to make all of this possible, I cannot thank enough all the reviewers, that's you. We had 180 reviewers who together wrote around 500 reviews, and these were curated into the decisions by 19 senior area chairs. So thank you so much for supporting our community. Okay, so just a little bit about trends that we see among the submissions. So supervised learning continues to be the most prevalent topic among the submissions. But as expected, we also saw a large number of papers on generative models, and then there are a few more analyses that we did on the topics that were submitted. So you can find these as part of the front matter in the proceedings. I'll not bore you with the details here. And now for the most exciting part of my job here. So we decided the paper awards based on the set of reviews that were submitted, the meta reviews by the area chairs, and a lot of deliberation by the program committee to try to identify papers that have a potential for significant impact on the field. So, drum roll. Okay, so in the proceedings track, the best paper is awarded to deep multimodal fusion for surgical feedback classification, and the honorable mention is awarded to compositional Q-learning for electropletion with imbalanced patient subpopulations. There's lots to say about these selections, but in keeping with the strict time limit that I have, I'll just name the papers, and you will have plenty of time to talk to the authors during the poster sessions. Going to the findings track, so the best paper goes to SANS-Formers, self-supervised forecasting in electronic health records with attention-field models, and the honorable mention goes to cohort trace data conceals disparities in clinical risk score performance. Congratulations to all the authors. That's not all. So we also have, as you know, two thematic sessions today, and we wanted to highlight papers that best reflect the work coming out of these topics. So for health equity and global health, the award goes to how fair are medical imaging foundation models, and the paper point of care real-time signal quality for fetal Doppler ultrasound using a deep learning approach. For our second theme, generative AI for health, the best papers are awarded to diffusion models to predict 3D late mechanical activation from sparse 2D cardiac MRIs, and the paper Medline, a clinician generated dataset from an instruction following with electronic medical records. So again, congratulations to everyone here. Okay, so I promise this is the last award slide. New to this year is award for the best paper among the first-time submitters to ML4H. So this is to encourage more newcomers into the field. So join me in congratulating Samir Khanna for learning generalized medical image representations through image graph contrastive pre-training. And the best demo goes to Evolution AI-powered digital cell morphology platform. So for all these awards, please come talk to us at the front desk to receive your certificates as well as award cash prizes. Congratulations. Okay, so we continue to expand the different mentorship programs that we have as part of ML4H, and makes the integral contribution to supporting the community, nurturing and welcoming new people into machine learning for health. So many of you, I know here, participated as part of these mentorship programs, either as mentors or mentees. These help us in just growing into a more robust field. So I want to thank each of you who contributed to these mentorship programs. Okay, so in closing, I'll just make some housekeeping announcements. By being here, so just to remind, we promise to abide by the ML4H Code of Conduct, which prohibits harassment, bullying, discrimination, inappropriate or unprofessional behavior. So if you see any issues during the day, you can contact the ML4H organizers at our email here, or come talk to us directly. Feel free to use the designated rooms on this floor, the third floor, which are set up as either lactation rooms, prayer rooms, or quiet rooms as needed. And one final thing for the poster presenters who are presenting in the first session in the morning, please set up the posters by 11 a.m. On the easels that you have been provided a number, and the easels have that number, the corresponding number for the poster. Finally, so putting together an event like ML4H is no small task, as you can imagine. I want to thank everyone involved in organizing ML4H. It took us more than 6 months of planning and dedicated effort to get us where we are today. I want to thank our organizers. You are truly a team of all stars. Thank you. And you'll be seeing a lot of us today roaming around. Will be the busybodies that you can identify from our badge. So come talk to us please thank us for our contribution. Okay, so apart from ML4H, we have many other upcoming events to stay connected with the community. So Newrips has 2 workshops focused on healthcare, and then we have the Chill conference that's happening in June next year in New York City, and venues like SAIL and MLC. So please do check them out. So with that, I'm going to hand it over to Divya to introduce our first keynote speaker.
My name is Divya. I'm a PhD student at MIT, where I work on building machine learning models and methodology that are resilient to unreliable data and the types of data you encounter in women's health. It's my pleasure to introduce today's morning speakers. So first we have Dr. Elaine, Nsoesie, who is an associate professor at Boston University School of Public Health and a leading voice in the use of data and technology to advance health equity. She led the Racial Data Tracker project at Boston University's Center for Anti-Racist Research and serves as a senior advisor to the AI/ML Consortium to advance health equity and research diversity, or the AIM-AHEAD program at NIH. Dr. Nsoesie has published extensively on the use of data from social media, search engines, remote sensors, and mobile phones for public health surveillance, and the implications of bias in health data and algorithms. She is passionate about increasing representation of underrepresented communities in data science, and she completed her PhD in computational epidemiology from Virginia Tech and held postdoc positions at Harvard Medical School and Boston Children's Hospital. We're lucky to have her here with us today, and with that, I will hand it off to Dr. Nsoesie to share more about her work.
Good morning, everyone, and thank you so much for showing up this early in the morning. My title is a bit different from what you might have seen on the screen before, but it's basically the same talk. So we're going to be talking about measuring the social determinants of health, social media data, life data, and image data. Since we're starting so early, I thought it would be interesting for us to have a quiz. And for this quiz, I have 3 questions. And I would like 3 people from the audience to respond to my question. So it doesn't have to be the same 3 people for all the questions. It can have different people. So here's the first question. What is the most important determinant in health? 1, culture. 2, employment and work conditions. 3, early life and childhood conditions. Income, family wealth, genetics, host environment, education, social support, healthcare, and influences. Anyone? And 1 person here in front. Should we have a mic going around?
I'll vote for 5.
5, okay.
I'll bet $10 for 5.
There's someone else here, so.
Number 10.
Here we go. The person is in shaking hand. You want to go for it?
9.
With more hands up, we can have another person. Number 3. Okay. It's so interesting that everyone has a different opinion about this. 7. Wow. Okay. Those are very relevant. Great. All right. We're going to get into the next question. She's basically the same question, but just, we can make it a little bit easier. List the top 3 determinants of good health. So now instead of choosing 1, can you choose 3?
Politics, 11, and 3 and 5. So early life, family wealth, and politics.
Very interesting. And can I ask why? Why do you think this is top 3?
Well, in the previous question, I was going to say politics, and I was going for early life or childhood conditions in the beginning, but then politics has a broader impact on
would say culture, genetics, and healthcare.
And why do you choose those three?
I would say culture because it determines a lot the level of activity in the food that we eat on a daily basis, which has a big impact on health. Similar for genetics, you pass down diseases from generation to generation, and healthcare just determines like whether people have access to basic healthcare resources.
I'd say it's income, family wealth, and early childhood conditions, at least based on Canadian
Okay.
because almost all the problems around housing security and food insecurity, which have been identified as major drivers, roll up to income insecurity.
Okay. And I think you kind of answered my next question. What do you think policymakers or politicians in your country consider the most important determinant of health? So we have one from Canada. Do we have people from other countries?
Beyond field healthcare and NHS, and they're more worried about getting more doctors in, nurses in, because how that people can't wait a long time for any kind of treatment. So I think it's a combination of politics and I would say there are a lot of things. I was just thinking money, getting healthcare.
I think you're seeing so many different responses because it all categorized under environmental conditions, which is determined by both how a patient interacts with their environment and how their environment interacts with them. And I think this question is difficult because the policymakers probably looking at what's most amenable to be interviewed on a large scale.
We have one more response from another country.
I'm from Mexico, and there it's more the stuff probably. No, sorry. Social support.
I think it's very interesting how all your responses are very different and your reasons are different. And I have a colleague that's with another company who come up with this paper where we have a survey asks same questions that I just asked you in 8 different countries to get opinions on what are the most important determinants of health, and these are the results that we get. So for most countries, most individuals ranked healthcare, except in China, which was quite interesting. Education came second for many countries, and then you start having things like the built environment, social support, and other conditions being ranked as the most important determinant of health. And then the perspectives also changed when you asked about what people think policymakers consider the most important determinant of health. Healthcare still came up towards the top, but then you started having people looking at things like politics and other determinants of health getting a lot more votes than healthcare or education, or some of the other ones that had a higher votes in the previous question. And what we're learning is that despite the fact that social determinants of health is something that has been studied in public health for a very long time and is very well established in terms of understanding the fact that it impacts health outcomes for different populations globally, is not something that everyone understands, and it's not something that everyone sees as an important determinant of health. So in public health, it's been shown that these factors have a very significant impact on health, but things like socioeconomic factors, physical environment, health behaviors, tend to have a lot more impact in healthcare. So social determinants of health is defined by individual are non-medical factors that influence health outcomes, the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include public policies and systems, developing agenda and social norms, social policies, which a lot of people brought up, and political systems, of course. And one example of recent or more recent example of a scenario where institutions have had very significant impact on health outcomes was the COVID pandemic. At the beginning of the pandemic, there was this assumption that everyone was being impacted the same, even though we actually didn't have data on how different racial ethnic groups were being impacted. Ibram Kendi, who is the director of Center for Anti-Racist Research, and a few other people began asking for data. So where is the data to show that different people or different racial ethnic groups were being impacted the same? And the data was not available for the CDC, so they started to collaborate with Atlantic to basically manually collect this data from State Department websites. So it was great. There were lots and lots of volunteers that worked on this project, people who worked in media, others who were activists, and wanted to see what does it look like, and on a daily basis would extract data from State Department websites, put it in one place so that it could be seen how COVID was impacting different populations. And this is what the found data looked like. But after looking at this data and looking at how different groups are being impacted in terms of cases and deaths, we began to think about what are various social determinants of health that we don't have good data for, or that we have data for, but people don't have access to that information. And so we created a project called the Racial Data Tracker. And the main objective of the Racial Data Tracker was to collect, analyze, and designate publicly available racial data across the structure of racial racism. And what we wanted to do was create a tool that anyone could access, everyday people could access and understand what racial health inequities or other health inequities across education, health, social services, how those would apply for their communities. So we created visualizations like the one you see on the screen, and we have a website that's currently up and available for anyone to access. That is interactive, and you can go and you can download data from the website. You can interact with different plots. You can also read narratives around the topics that we focus on. We focused on two topics for this initial, for this part of the project. We looked at racial wealth gap, and we looked at health and social safety net policies and how those policies are actually working in the US. So the root causes of health inequities are policies, practices, and structures that prevent some groups from achieving optimal health. So my research has focused on thinking about how do we understand these different root causes of health inequities and how can we create policy solutions to address these inequities. And this is how I define health equity. Health equity is assurance of conditions for optimal health for all people. Achieving health equity requires running all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources that others in need. Health disparities will be a limited health equity is achieved. And health equity is easy to talk about, but it's not always easy to implement. A lot of people tend to think of equality when they think about equity. And equality basically means that everyone gets the same thing, regardless if it's even alright for them. So if we say everyone needs a vehicle to go around, we give everyone a bicycle, whether they need a bicycle or not. But equity, on the other hand, says that we need to understand what the barriers, what the circumstances and conditions that prevent people from achieving optimal health, and then remove those barriers or give them the resources that they need to overcome those barriers so they can achieve optimal health. So different people will get different types of vehicles in that case, so everyone have at least a bicycle. And sometimes equity requires giving some people more than others, and that's something that's really difficult for us as humans to understand. So you can have two different people, but because one person is closer to having the resources or has fewer barriers to get to optimal health, the person that has more barriers might get more resources than the other person. So my current research is focused on the use of machine learning to improve measurements of structural determinants of health, to quantify how historical policies, structural mechanisms continue to influence present-day health outcomes, and to study and put those policies and transform systems and structures to improve health outcomes for everyone. I've missed the work, the type of data sets that I've been on the screen. When I started in this field, a lot of my work was focused on infectious diseases. So I wanted to understand things like how do we use crowdsourcing data to study the spread of like illnesses in different communities. How do we use data from places like Yelp to study foodborne illnesses, so when people go to Yelp and report that they ate at a restaurant and they got sick, can we mine that data make it useful for public health officials so they can investigate foodborne illness outbreaks in their communities. And there have been departments of health that have used it. So New York City Department of Health is a good example that used Yelp to discover outbreaks that were not being reported to them. We've also used data from places like Amazon to focus on food safety issues specifically. Can we identify unsafe food products before they become a problem in the general community? A lot of the work that I've been doing recently, we've moved a little bit from infectious diseases and focus more around the risk factors and causes of inequities. So that work is focused mostly on data from some data from social media, but a lot of data from remote sensing, place, mobile phone data as well. I'm going to give you a few of those examples too. But when we started looking at inequities, I started with food and physical activities. We're trying to understand how different people talk about diet or food on social media platforms and whether that can be useful for departments of health, and how people talk about physical activity. So the first step that we did for those studies was trying to see if what was being discussed on social media actually mapped to what we were seeing from survey data. So we looked at survey data from the CDC, collected data on physical activity from Twitter or X, and we mapped this data at the county level, and we looked at discussions around physical activity and found that for counties where people talked a lot about exercising, that actually correlated with lower leisure time physical inactivity space and data from the CDC. And similarly, when we looked at how people talked about food and exercise combined, that tended to be associated with lower obesity prevalence in counties in the US. During the COVID pandemic, we looked at how people were talking about food and how it had changed when we compared before the pandemic to what was happening during the pandemic. And so we looked at healthy food, fast food, alcohol. I'm not going to talk a lot about methods, but I'm happy to discuss methods if people have questions around methods during the question time or after. So we looked at healthy food, so we would look at tweets and what kinds of foods people mentioned, and then map that to a database from the FDA that had different food types and whether those foods were classified healthy or unhealthy. And when we looked at our data, we saw that if you compare before the pandemic and during the pandemic, mentions of healthy food actually went up, mentions of fast food went down, and mentions of alcohol went down. There were actually studies that showed that there was more alcohol consumption during the pandemic compared to before the pandemic, but people were just not talking about it as much as social media. So for county level findings, what we observed was that the more time people spent at home, the more we talked about healthy foods, the more the number of grocery stores per 10,000 inhabitants in the county was associated with an increase in healthy food tweets. And when we look at the liquor store, that was associated with an increase of tweets referencing alcohol during the pandemic. And so what we were trying to do here was link what we were seeing on social media to what we had in the built environment to see whether there was any association between what people were talking about on social media and what was available to them in their events. When we looked at the state level, we saw that the share of healthy food tweets increased in 49 states during the pandemic compared to pre-pandemic. Fast food tweets decreased, as I mentioned before. Alcohol tweets also decreased across most states. There were only 6 states that experienced an increase in alcohol tweets, and you can see them on that. So we continue to think about food and exercise and the impact on how alcohol specifically obesity. But there's also been a lot of work that has shown that for people to exercise, they actually have to have the right environment to exercise. So where you live is a very good determinant of whether you're going to be able to exercise or not. If you don't have the spaces that encourage you to exercise, then you're less likely to exercise. So for this study, we looked at satellite countries and obesity in 6 different cities. There have been several studies that have linked obesity to built environment variables. But there are differences in measures and measurements, which sometimes makes it hard to compare those findings. So for example, you have one study that looked at the density of fast food restaurants and how that relates to obesity prevalence. Another study looked at the density of fast food plus other types of restaurants. So when you start comparing and might have slightly different results. So when you start comparing, it's not always obvious like what the measurements are implying. And so for this study, we wanted to see if we could use deep learning to extract information from images and create a single indicator for each neighborhood. So with each census tract, could we say this is an indicator representing the census tract, and can we look at how that relates to obesity prevalence in that city? So we looked at 6 different cities. We selected cities that had high obesity prevalence and cities that had low obesity prevalence. And then we also get estimates of the numbers that you see that in parentheses, it's the rankings in terms of obesity prevalence for those cities. And then we got data from the CDC on obesity prevalence. We also looked at data, points of interest data, because we wanted to compare, since a lot of studies have already looked at density of things. Could we just look at points of interest and calculate the density of different things like restaurant and fast food to compare how well our study or our the indicators that we created from satellite images, how well they can compare to points of interest there. And then there was also a lot of conversation around, well, there's been a lot of work that has shown that things like obesity prevalence are also strongly correlated with income. And so we wanted to have income data as well as a way to compare and see how well we're doing. And we got satellite images from Google. So we use transfer learning for this analysis and apply the estimate for regression analysis. And so on one side, you have the actual obesity prevalence, so that's on the left. And on the right, we have a model estimates based on satellite imagery data. And what we found was that we can actually do pretty well in terms of estimating obesity prevalence simply by looking at satellite images in neighborhoods. And when we went back and looked at what the images were actually, what was most significant images, mostly mean space in the initial analysis. And so, but we've also hypothesize that there were additional things that we're capturing, because if we just look at the same, if we looked at things like income or just green space to predict obesity prevalence, it didn't do as well as our indicators that were constructed from satellite imagery. In some cases, we overestimated obesity prevalence, and those were usually in cases where you have neighborhoods that don't have a lot of factors that would encourage physical activity, but still have low obesity prevalence, either because there were higher income neighborhoods and people could access things like gyms and they needed to offer oils. And then other places we have like low obesity estimates, obesity prevalence estimates, but they were higher in those places. And so those were places like Seattle where everything is practically green. So people can, it might encourage a lot of people to go out, and some people can still choose not to go out. So this was consistent across the 6 different cities that we looked at, whether we looked at Memphis, Tennessee, or San Antonio, Texas. And when we compared our estimates for the indicators that we extracted from satellite imagery to a point of interest data, we saw that our estimates were much better than what we were getting from points of interest data. So the study attracted a lot of attention, there was a lot of discussion. I had a lot of meetings with public health researchers. And one of the questions they were asking was, how can we use this? So you create these indicators, what new information is it providing to us? How can we use this for policy making? What else do you observe in the built environment? And so we began to think more about this topic and also think about what other people were doing in this space. So there's been a lot of work in the social sciences in the last several years that have looked at street view images as a way to do audits of the neighborhood in cities around the US. And so we wanted to see if that data could be useful. That's the first step. We just understand what are some of the useful indicators that we can extract in terms of the built environment, and how can we study that in relation to health outcomes. So we worked with a colleague who's been collecting them for a while, and she has about 164 million images, and she's classified them using convolutional neural networks and identified very specific indicators in the built environment. So things like green space, crosswalks, non-single family homes, so that's S and H, and several other indicators. And for those we selected 5, I'm going to highlight those 5. And we also chose to focus on urban census tracts because when we looked at rural data, it wasn't very good. And we thought if we started with urban census tract, we can see this is actually useful and what next steps we can take in this analysis. So we focused on 59,000 urban census tracts for which we captured the data. We had 2 research questions. The first question was, can we quantify racial and ethnic disparities in built environment resources? The second question was, can we quantify how the built environment mediates the association between visual composition and health outcomes. So the first step was categorize neighborhoods. So we looked at the data that we have in each neighborhood, what was the predominant racial ethnic group, and we created this categorization. So we have predominantly black people, predominantly white people, predominantly minoritized racial or ethnic group other than black people, and then you have unclassified neighborhoods. And then we also went back and looked at, actually I should give this credit to one of the reviewers. One of the reviewers came back to us and said, your classification is so interesting, but have you looked at redlining? So we went back and looked at redlining. So for those of you who might not know what redlining is, in the 1930s, the Homeowners Association in the US created color-coded maps where they delineated areas that they deemed risky for investments, and this was based on very objectively basis criteria. So for A neighborhoods that we consider the best, those predominantly white neighborhoods, and then as you go down, you get to D. D were considered hazardous or classified red, and those predominantly members of racial and ethnic minority groups. And it's been shown, several studies have looked at the impact of redlining on neighborhoods and health in the US, and have shown that these policies associated with resident health disparities, including return violence, asthma, and mortality. And the interesting thing about policies is that you can end policies, like this policy was ended in the 1960s, but other policies came after that and adopted the same criteria. So it wasn't as effect, but they were basically doing the same thing. So even though the policy set has ended, it still had an impact on health outcomes in neighborhoods in the US. So 200 cities were classified under this policy, and these cities have changed. Obviously, boundaries have changed over time, and we're only able to capture only a subset of those neighborhoods. So we classified them into D, C, B, A, S, and other as shown. And these are the indicators that we focused on with the dilapidated buildings, green spaces, crosswalk, non-single family homes, and single homes. And selected these. Some of these have been studied pretty well, so things like green spaces, as I mentioned, have been studied really well. Dilapidated buildings not so much because they're harder to measure. So we're hoping that these data sources can provide an alternative way for us to capture some of this data. So our major findings were that compared with other neighborhoods, predominantly white neighborhoods have fewer dilapidated buildings and more open space. So green spaces versus with more good health. And when we looked at our redlining data, as we went from A to D, things got worse. So when you compared neighborhoods that were classified as H and neighborhoods that were classified as D, there were significant differences in access to resources that encourage good health. So our next question, as I mentioned, was to look at health outcomes and this, how structuralism within the built environment indicators with the association between neighborhood racial composition and health outcomes. And we focus on sleeping problems, diabetes, prevalence, and asthma prevalence. And one other thing we did was compare our classifications of neighborhoods to the redlining classifications and found that they're actually quite comparable. They're significantly correlated. So our major findings in terms of health was that the type and quality of homes is quite important for sleep quality and environmental exposure. So non-single family homes were a more significant mediator of health crisis. So why does this matter? Historical policies continue to impact our lives today, as I mentioned, and if we don't measure things, we can't change things. So we don't know what's impacting health outcomes, we can't really do anything about it. Policies have created disparities, and I think policies can also be used to correct these disparities in health outcomes. This is my last study. So one study that we did during the pandemic, which I thought was quite interesting and I would love to mention, is a study that focused mainly on income, physical distancing during the COVID pandemic in the United States. So when physical distancing policies were put in place, you want to hear, there was a lot of discussion around how some people were not observing these policies and were going about doing whatever they wanted to do. And so we wanted to study whether there was any relationship between income and whether someone would actually physically distancing or not. And what we found was that income determines whether you were able to stay at home or go to work, but non-work visits were not really impacted. So to show you this visually, We got mobile phone data for millions of individuals and looked at these at the blood group level. And what we found was that before the pandemic, the lowest income quintile spent the most time at home, while the highest income quintile spent the least time at home. And after the pandemic started, this completely switched. People that were in the lowest income quintile were spending the least amount of time at home because most of them were going to work. They were doing what we would consider essential jobs, so they had to go out and they had to interact with people. And so when you look at what was walking outside of the home, that relationship completely switched. So if you even think, even before social distancing policies were put in place, some of us were already spending time at home. And that's what we saw in the data. So before we even had some of this policy in place, there were many people from high income groups that were already spending time at home. And so when we looked at other non-work visits, there was no observable difference across these income groups. A lot of my ongoing research right now is focused on racial equity in cities. So try to understand how cities are addressing racial equity, what are their plans around this, and how machine learning can help us better understand what the impact is. And then there's a lot more new research on web classification networks that we're looking at to see how it changes or impacts the findings that we've seen so far. So thank you, and any questions? No?
Thank you for that talk. We'll save questions for the panel. So next we have Dr. Emma Pierson, who is an assistant professor of computer science at Cornell Tech and a computer science field member at Cornell University. Do you like that one? You can actually set up your laptop while I do the introduction. She holds a secondary joint appointment as an assistant professor of population health sciences at Weill Cornell Medical College. She develops data science and machine learning methods to study inequality in healthcare. Her work has been recognized by Best Paper, Poster, and Talk Awards, an NSF Career Award, a Rhodes Scholarship, and MIT Tech Review's 35 Innovators Under 35. Her research has also been published widely at venues including ICML, KDD, WWW, Nature, and Nature Medicine, and she's also written for the New York Times, 538, Wired, and various other publications. Thank you for joining us today, and looking forward to the talk.
Wonderful. Thank you so much for the kind invitation to speak here. On the one hand, Elaine is always a tough act to follow. On the other hand, I think the very nuanced answers to the quiz she hit us all with at 8 o'clock in the morning reveal that this is a group that thinks carefully about and cares deeply about health equity. So it's a pleasure to get to speak to you today. Broadly, my work seeks to use machine learning to increase health equity, and it does so via two main pathways. The first is around making fairer decisions. The second is around understanding the health of understudied populations. Today I'm going to be talking to you primarily about that first direction. One reason I've been thinking a lot about this is we actually just released a Coursera course on this. This is joint work with KEYNOTE and with Jeff Leake, and it's freely available on the internet if you want to take it. It's designed to be widely accessible. My grandma is currently taking it. It really is intended to be open to all. And this class is structured around 10 basic lessons for sort of designing fair algorithms. And I think one reason this seemed a natural organizing structure to me is that in one way or another, a lot of the papers I've written over the past 5 or 10 years are sort of related to these lessons in one way or another, which I tried to illustrate with this maybe not that helpful hypertrophic graph. This is obviously too much to talk about in 20 minutes, so I'm going to focus on 2 lessons today. The first is around the critical importance of the prediction target, the thing we train our model to predict, and then the second is about seeking out use cases which affirmatively improve equity. So let's jump right into it. So I think there's a strong case to be made that like if you did some like March Madness thing of like most important lessons in algorithmic fairness, like this may be the single most important algorithmic fairness lesson of the past 5 years, the critical importance of the thing you train your model to predict. A canonical example of this, of course, is the science paper that appeared in 2019 about how when you train a model to predict cost rather than health, you end up with a racially biased predictor. And a lot of my recent work is focused on the issue of what you do when the target you would ideally want is unavailable, which of course, as you know, in healthcare is frequently the case, right? The things we care about are hard to measure. And so a lot of my recent work is focused on this challenging case about using machine learning to detect and potentially correct for biased target variables. To be very clear, there is no magic here, right? Like statistics cannot invent for you your ideal target variable out of thin error, you're going to need some source of leverage, and that leverage, in my experience, is one of two things. It's either conditional data, or it's additional assumptions that you're willing to make that are plausible in your setting and that enable you to constrain what the real target may be. So let me tell you about two papers in this regard. The first is led by Elaine, who actually is presenting a different paper here, but I'll let her talk about that in her own spotlight. So yeah, so this is a paper which is currently in review at MD Women's Health. And it deals with the setting that we frequently confront in medicine, which is often we would like to be able to train a model to predict whether a patient has a condition. That's our desired target. But of course, what we actually observed in EHR data, right, is not whether the patient has the condition, but whether they have been diagnosed with it, coded as having it. And in the presence of underdiagnosis, patients may lack diagnoses for conditions that they truly have. And worse, if diagnosis rates vary across groups, right, some groups are more underdiagnosed than others, just training on diagnosis data will foreseeably introduce bias. And so this problem is unsolvable without further assumptions. Those of you who've worked in this area might recognize it as a PU learning problem, which is code for a difficult problem. But we show theoretically and empirically that you can make progress by making what's called a covariate shift assumption. Namely, that if two patients have the same symptoms, they are equally likely to truly have the condition regardless of what group they're in. And using this assumption, and even under plausible violations of this assumption, we show that you can figure out which groups are most affected by a condition, even in the presence of differential underdiagnosis. And this facilitates interventions which can benefit those groups. And we apply our method to identify the groups with the highest rates of intimate partner violence, which is a very underdiagnosed condition, of course, which motivates this work. We apply this in two large EHR data sets. And we find higher prevalences of IPV among patients who, for example, are on Medicaid, who are not legally married, or in lower income zip codes. And so these findings, I think, by themselves are important, but also the method is more generally applicable in other underdiagnosis settings, or even more broadly in other positive unlabeled settings. Here's another example of this, and we're presenting this as a poster here today, so come chat if you want to. Another frequent medical setting is you want to train a model to predict whether a patient has a medical condition, say like COVID, and you at least know whether the patient was tested for it. So it's slightly easier than the previous setting because you at least know whether the patient was tested. You observe two pieces of information. Were they tested? And if they were tested, did they test positive? If so. So as opposed to only one piece of information in the previous setting. But this setting is still very hard because you've got all these untested people and you don't observe labels for them. You don't know whether they truly have the disease or not. And the untested patients can, of course, be very different from the tested patients. So you don't want to just train a model on the tested patients and assume it generalizes to the untested patients. You've also, again, got the possibility of bias, which arises if some groups are more likely to be untested than others. So how do we make progress here? One fundamental reason this problem is hard is the wide range of possibilities for the untested patients, right? They could all have COVID, they could never have COVID. So to make progress, what we do is we narrow down the range of possibilities for the untested patients using domain constraints, which are plausible in medical and other settings. For example, we know that not all the untested people actually have COVID. I mean, I hope so, because there are like a lot of people in this room. We know that you can't all have COVID because we know something about the overall prevalence of COVID in the population. So we place a prevalence constraint on the model to narrow down the range of possibilities. And so basically what we do overall is we propose a Bayesian model class which captures this setting of sort of untested patients, and we also propose two domain constraints, a prevalence constraint and something that we call an expertise constraint, which are plausible in medical settings in which we show theoretically and empirically improved risk estimation. This work is led by Zitnik and Harrer. We have a poster here, drop by if you want to chat. We should also be giving a spotlight on it later this week at the distribution shifts workshop, so come back to that. Okay, so to summarize this part of the talk, the choice of the target variable is crucial. Bad targets can introduce bias, okay? Because generally when your target is flawed, it's not flawed in some way which sort of affects us somewhat equally, right? That's not the way the world works. It tends to affect some groups more, and thereby the gap between what you have and what you want, it introduces bias, sort of inevitably and predictably in the settings I've seen. The thing we'd ideally want, the desired target, is often unavailable, so it's hard to measure the things we care about, but in some cases, machine learning can help us detect and correct for the bias induced by bad targets. Second part of the talk, about seeking out use cases which affirmatively improve equity. So the previous part of this talk may have sounded quite negative to you. Like algorithms are flawed in many ways, and we train them on things that perpetuate bias, etc. But actually, I remain quite very optimistic about the ability of algorithms, machine learning, and data science to improve the equity of decision making. And the reason is that, I've sort of studied the world as it exists in the absence of algorithmic decision making, and it turns out that world is deeply unfair. So this is sort of a somewhat twisted reason I remain cautiously optimistic about the potential of data science and machine learning to make things fair, because I've spent a lot of time studying the inequities which exist in human societies, even in the absence of algorithms. So let me give you some examples of this from our previous work. We spent a long time working with journalists to compile a large-scale data set on police traffic stops, which we cleaned up and made available to the public. You can download it on the internet right now. And then we analyzed this data for evidence of racial discrimination, both in the decision to stop the driver and in the decision to search a driver, develop Bayesian models to assess specifically that search decision. And we found broadly that search rates were higher for minority drivers, so searches were less likely to find anything, and this was indicative that they were being searched at lower thresholds of evidence, basically indicative of racial discrimination. We worked then with journalists at the Los Angeles Times to make it possible for them to apply our statistical methods that we developed. They wrote a news story using these methods and showing that the LAPD was searching minority drivers on the basis of less evidence. And then in response to that, the LAPD, this is the good thing about working with journalists, by the way, is that when they write stories, like things actually happen, which is not actually true of many of the papers that I've written. And in response to this, the LAPD announced that they were going to curtail or cut down on random vehicle stops in an effort to reduce this racial bias. Here's another example of this, and this actually dovetails nicely with COVID-19 mobility work just discussed. So, of course, mobility profoundly links to the spread of COVID-19. So what we did here was we took large-scale mobility data from cell phones, applied machine learning to sort of clean it up into a network, linking neighborhoods to places. So think, tens of thousands of neighborhoods, hundreds of thousands of places, billions of hourly edges tracking the flows of people between those two. On top of this mobility network, we then put a sort of SEIR model, standard epidemiological model, which we adapted for this network setting, to model the spread of COVID-19 in a fine-grained way. We use this then to understand how mobility links to inequality and infection rates that arises. And one of our findings actually is so one thing this model naturally does is that it predicts correctly the emergence of higher infection rates in, for example, poorer neighborhoods on the basis of mobility alone, without being told anything on demographics. It also gives insight into two mechanisms that underlie that. One of them actually was just discussed. It's very nice that these two papers parallel each other about how people from lower income neighborhoods were not able to reduce their mobility as much, in part because they were more likely to be essential workers. The other is that when people in these neighborhoods did go out, even to the same types of places, those places tended to be smaller and more crowded and more dangerous. So, for example, if a person from a rich neighborhood and a person from a poor neighborhood both went to a grocery store, the person from the poor neighborhood would tend to go to a grocery store that was smaller and denser and therefore exposed them to higher risk. This work too had a fair bit of national and international impact in terms of its impact on sort of reopening policy. The graph at the top right is in Polish, which I do not read, but I did help make the graph, so hopefully they rendered it correctly. Okay. In more recent work with mobility data, we've used it to study socioeconomic segregation, which is something of clear importance for sort of public health and for social mobility and various other things. Segregation is a very important thing to measure, but it's hard to measure. The reason it's hard to measure is it's like how much people mix with each other from different groups, loosely, right? But it's hard to know who everyone comes into contact with over time. And so classically, the way people have often measured this is just using census location, like where you sort of sleep at night. The problem with this, of course, is it doesn't capture who you mingle with, like at work or at leisure, so on and so forth. So we use cell phone mobility to ameliorate this problem. Specifically, we sort of take minute-by-minute location data for about 10 million people in the United States. We then apply, whatever. I'm not going to go into the algorithmic details, but it's a bit of an early problem that you don't want to solve with like a doubly nested for loop to find all pairs of people who cross paths. We then identify, all of this path crossing network, the many people who cross paths. On top of that, we put a new measure of segregation, which sort of extends classical definitions to the network setting to basically, bottom line, measure segregation in a way which accounts for who people actually cross paths with when they're not just in their homes at night, and we show, for example, higher segregation levels in larger cities. So So zooming out from these specific examples, I think it's important to understand that machine learning does not just inevitably increase inequality in healthcare and public health. It can also help us understand and thereby reduce it. And the point I want to close on is how a similar lesson is playing out today with large language models. This is very recent work with Livia and then also with Rashmova and John Kleinberg, and then a whole bunch of other excellent co-authors, including Marinka, will be speaking later today. I know there's an LLM session. Sorry if I'm not allowed to talk about LLMs. Yeah, but I do think they have interesting applications in health equity, so I want to talk about that. So there's been a ton of important and invaluable discussion about how large language models can increase bias and inequity. And actually, JP and Raj and I spent a while over Thanksgiving specifically sort of trying to catalog, we looked at all the LLM papers which focus on equity impacts, and we found that about 85% of them focus on preventing harms. And this is a vital discussion, but equally vital and much less discussed is the more opportunity-focused counterpoint. Namely, what promising applications do LLMs enable that could improve equity? And the reason this latter question matters is that there are many choices which determine the impact of AI. And a fundamental choice very early in the pipeline is the problems we choose to apply it to. If we focus only later in the pipeline, we will miss an important opportunity to guide these models to more equitable impacts. So addressing this gap, we pulled together a whole bunch of folks in health equity and LLMs to collaborate on an article enumerating applications of LLMs to improve health equity. And specifically, we argued 4 use cases. The first is using large language models to detect bias from text, for example, in clinical notes and medical textbooks. We know, of course, that human biases contribute to inequity. In healthcare, for example, doctors describe Black patients as difficult more often than they describe white patients this way, and this has been shown to lead to a lower quality of care. LLMs can improve our ability to detect human bias from text data. For example, previous research has found evidence of bias in stigmatizing language in clinical notes, but has often relied on relatively rudimentary linguistic analysis methods like searching for specific keywords. LLMs can more precisely characterize more subtle linguistic biases, for example, in sentiment and tone and stereotypes, thereby enabling more comprehensive characterization of clinical biases. A second application we're very excited about is creating structured data sets from unstructured text for health equity research, including, for example, extraction of social determinants of health. So structured data sets, of course, track a standardized set of fields in a consistent way, for example, the race and health insurance provider of the patient, and they're obviously invaluable to allow us to quantify disparities and develop policies to mitigate them. But creating these data sets often requires substantial human effort to extract the necessary information from the raw text data. For example, within like there are examples where journalists and activists manually scour like news articles to create databases tracking violence that disproportionately impacts marginalized populations, for example, police shootings or gender-based violence. And we're currently in active conversations with journalists and activists to help create structured data sets here. The third application we're interested in is improving equity of access to information by helping provide answers to patient questions for patients who lack easy access to a medical provider, or by helping translate clinical jargon into language which is actually understandable by people without MDs. And again, we're in active conversation with practitioners here around this application. And then a final application we're quite interested in is making matching systems more equitable, for example, by improving clinical trial matching. This might include, for example, parsing complex clinical trial inclusion and exclusion criteria to suggest eligible patients from underserved groups, or by understanding how modifications to criteria could impact patient diversity. Overall, the point I want to close on is this. As practitioners who care about equity, we want to do more than clean up after people who don't. We want to do more than tinker around the edges of use cases which intrinsically entrench power. For example, ensuring that LLMs don't use stigmatizing language when they issue mass insurance denials. Like, I guess it's good if they don't stigmatize people when they do that, but like the use case is intrinsically invalid. We should set sights higher than that. We should recognize that this is flawed but revolutionary technology, and we should turn it affirmatively to serve the use cases we care about and the populations we care about in pursuit of a more equitable world. That's all I got to say today. Thanks very much for your attention and for the invitation.
Excellent. Okay, so next up we have Dr. Milind Tambe, who is a Gordon McKay Professor of Computer Science and a Director of the Center for Research in Computation and Society at Harvard University. Concurrently, he is also the principal scientist and director for the AI for Social Good team at Google Research. He is a recipient of numerous awards. For his work on AI and public safety, he has received the Columbus Fellowship Foundation Homeland Security Award, in addition to commendations and certificates of appreciation from the U.S. Coast Guard, the Federal Air Marshal Service, and Airport Police at the City of Los Angeles. Additionally, Professor Tambe and his co-authors have received 17 Best Paper Awards, which includes his 1997 paper, Towards Flexible Teamwork, in the Journal of AI Research, which won the AAMAS Influential Paper Award. Prior to Harvard, Professor Tambe co-founded the Center for AI and Society at USC, which is one of the first centers in the country focused on AI for social impact. Without further ado, Dr. Tambe.
Okay, so I'm going to talk to you today about improving maternal and child health outcomes. So for more than 15 years, my team and I have been focused on advancing AI and multi-agent systems for social impact, focusing on topics of public health, conservation, and public safety and security, with the goal of optimizing our limited intervention resources. So in the same theme, we've been conducting work for AI for maternal and child care. And I'm very excited to talk to you today about our work with the world's two largest mobile health programs for maternal and child care. In India, the first one, called ML4H, is focused in Mumbai and works with 200,000 mothers enrolled at a time. The second is a national program in India called KEYNOTE, where 3 million mothers are enrolled at a time. Now I'll talk to you about our results improving access to health information and also some of the improvements in health behaviors. So the motivation for this work is the UN Sustainable Development Target, that the maternal mortality ratio, mothers dying during childbirth and soon after, should be below 70 per 100,000 live births. Where we are today, in terms of Western Europe, the numbers are significantly lower than the UN target. In United States, the numbers are rising, but still below the UN target. In the rest of the world, though, the numbers are significantly higher than the UN target. And we'll focus on India, where the numbers are declining, but still higher. We've been very fortunate to be working with a nonprofit called Arman in India, which works with 20 states, works with 41 million mothers. It's a large-scale nonprofit, and we've been very inspired by the founder of Arman, Dr. Hegde, who points out that pregnancy is not a disease, childhood is not an ailment, and dying due to a natural life event is not acceptable. I met with Dr. Hegde at a Starbucks in Mumbai in 2019 and was very impacted by the work that she and her organization are doing, and decided to orient my research group towards the cause that we serve. So the first project that we decided to focus on is the ML4H mobile health program for new and expecting mothers. This is a weekly 2-minute automated voice message that gets delivered to these mothers. A message, this is a small snippet of a message that gets delivered. It's in the local language, it's delivered in a sing-song manner. And for example, this is talking about for you and your baby to be strong, you need lots of iron, etc. So there's 141 such messages that get delivered from the time the mother registers to the time the baby is 1 year old. And 2 million mothers have so far benefited from this program. And in randomized control trials, Arman has shown that mothers who listen to these 141 messages, compared to mothers who don't, benefit significantly in terms of their own health and the health of the baby. For example, 30% increase in infants with triple birth weight at the end of the year, and other such benefits. So where do we come in? Unfortunately, 30 to 40% of the mothers who enroll may become low listeners or drop out of the program over time. To understand why, Arman took us around to the sites in Mumbai where they enroll mothers, where these beneficiaries live. Now, I've grown up in Mumbai, I understand these neighborhoods to some degree, but going into the homes of these beneficiaries, where these 95% of the families that Arman serves are below, or living below the international poverty line, it reveals the pressures these mothers are under. So what can we do? We have a limited intervention resource, which is a call center from where these call center workers, health workers, can give calls to these mothers to encourage them to stay in the program. The But the call center is small and the program is very large. So specifically, we have a large number of beneficiaries, 200,000. Every mother gets a health message every week. So all 200,000 get these health messages. But from the call center, we can only choose 1,000 of these mothers to give a service call to encourage them to stay in the program. And so the question becomes, which 1,000 so as to maximize the total number of health messages that are listened to. Just to give you an example, suppose we have a health worker who has 5 mothers under care, 4 shown in red have not listened to health message, and 1 shown in green has. Now, this health worker has to choose which 2 mothers in this case they're called. So supposing she chooses the first 2 shown in red, as a result of this service call, these 2 mothers get motivated to stay in the program and turn to green. There's another mother who automatically on her own turns to green, but there's still 2 in red. And so again now, next week, who do I call? So the health worker may choose the last 2, but this turns out to be a bad choice because not only do they not turn to green, but the other 2 mothers who are in green also turn to red, they stop listening. So the point here is that there's a challenge in choosing these 1,000 beneficiaries. A call may not change a beneficiary state, but beneficiaries may change state of their own. So in choosing these 1,000 beneficiaries out of the 200,000, we turn to restless bandits of choosing K out of 10 hours per week. For those who may not be familiar with these restless bandits, each arm of a bandit is a Markov decision process where a mother might be in a bad state. She has not listened to a health message, or a good state. She has. We have actions to either intervene by giving a service call or not. And there's this transition matrix which shows the impact of our call. So if we call the mother with a service call, probability shifts from a bad state to a good state is 0.8, but if we don't, then it's 0.2. So in reality, of course, we have 200,000 such arms, and now we have to select 1,000. This problem is piece-based hard. So the way these problems get solved is by computing a Whittle index for the current state of each arm. Formally, this is the infimum subsidy that we can offer the passive action in a state so that its Q value becomes equal to the Q value of active action. What it is doing essentially informally is computing the benefit of the intervention. And so we can rank all of the 200,000 arms and pick the top 1,000. There is no out-of-the-box algorithm to solve for this, but we have fortunately worked on an algorithm in almost 2016 that we use in this process. There is, however, one key challenge, which is that we don't have these transition probabilities. What we have, though, are previous data from mothers who had enrolled. So we have features for these mothers: age, income, education, etc., and engagement sequence. The mother was in a bad state. She got a service call, remained in a bad state, service call, good state, etc. So based on all of this past data, we can learn a model that makes a prediction about the behaviors of these mothers, the transition probabilities. And then we can use a Whittle index to choose the top K. So this is a 2-stage model where we first maximize learning accuracy, and then we optimize by choosing the top K mothers, maximizing decision quality. And now it's time to evaluate the system. So we ran a large-scale study with 23,000 beneficiaries, large-scale application of restless bandits for public health. They were divided into 3 groups. One is restless bandit group, one is round-robin group, and then a current standard of care group. All beneficiaries, it's important to understand, in all of these groups, always got a health message each week. What differed, though, was that how we gave them service calls. We gave 225 service calls per group because they're limited resource, and this was done for 7 weeks. In the restless bandit group, the service calls were determined by who had the top Whittle index. In the round-robin group, it was the first 225, then the next 225, etc. And in the current standard of care group, no service calls went out because that's the current standard of care. And the question then becomes, how many more health messages are listened to in each of these groups compared to the current standard of care? And what we find on the x-axis are weeks, on the y-axis is cumulatively how many more health messages are listened to. And we can see that with the restless bandit group, more than 600 messages are listened to, shown in blue, whereas in the round-robin group, there's hardly any improvement over the current standard of care. The main point to take away is that it's important to optimize the service calls because something like a round-robin hardly does any improvement. And the restless bandit group cuts the drop-off rates over the current standard of care by 32%. Having done this work, we noticed though that we can further improve these results by using decision-focused learning. I talked about this two-stage model where we first maximize learning accuracy and then optimize decision quality. However, maximizing learning accuracy doesn't translate necessarily into maximizing decision quality. In fact, I can show you these results from this real-world data set in Arman. The orange data set has a higher predictive accuracy, blue has lower. So we would imagine that service calls made using the blue data set should lead to lower solution quality, lower amount of engagement from the mothers, but in fact the results are exactly the opposite. Blue leads to higher amount of engagement. And why might this happen? And this is because if you imagine now this as an illustrative example, this data set where there's some feature on the x-axis, transition probabilities, on the y-axis you can see these blue dots, low risk mothers, largely number, red dots are fewer, high risk mothers. And if we maximize our learning accuracy, we may learn this green regressor line, which, as you can see, is good at learning accuracy, but has a lower decision quality because it misses all the high risk red data points. A decision-focused learning approach modifies the loss function to directly maximize decision quality. And we may learn this other green regressor line, which obviously has lower learning accuracy, but has a higher decision quality. So, and this decision-focused learning draws gradients directly from the solution quality. And having built this decision-focused learning model, now it was time to again test it in the field. And so we ran another field study with 9,000 beneficiaries, 3,000 in the decision-focused learning group, 3,000 in the two-stage model, and 3,000 in current standard of care. If you look at predictive accuracy, the two-stage model has a higher predictive accuracy. But actually, in reality, when we do service calls based on two data sets, what we find is that the decision-focused learning approach leads to higher amount of engagement from the mother, shown in blue, and the two-stage leads to is lower. So this decision-focused learning model with restless bandits is now what is deployed with Arman. The system is called Saheli. It's an acronym, but it also translates into the word friend in Hindi. This is just to tell you that we've spent enormous amounts of time coming up with a good acronym. It has served over 315,000 beneficiaries. It has been in continuous use since April of 2022. It has prevented 30% of drop-offs. And for the lowest 25 percentile of listeners, the increase in content exposure to health is more than 130%, more than double. Most recently, we've also done a study trying to understand the health impact of these interventions. So this was with 60,000 mothers, two arms, restless bandit and current standard of care. And initial results from a postnatal care survey with more than 2,000 of these mothers, and there's some criteria which mothers were selected. We find that there's a significant improvement in mothers who have improved eating or taking actions for better health, whether it's taking iron tablets or calcium tablets and so forth, compared to the current standard of care. And there are other improvements in indicators for health, such as improved understanding and focus on quantitative measurements for health, which have been lacking previously. So with all of this, with the system deployed, we have got good reaction from Dr. Hegre. There's a YouTube video if you wanted to take a look at that. AI for Social Good in partnership with Arman, where she points out that we are able to reach out to more and more women each week and get them back into the fold and save lives because of AI. I'm going to play a small video, hopefully it plays, and it shows the reaction of one of the beneficiaries. The video will not play.
There's no audio.
Okay, well then, all right, you can just see this mother, maybe we see a silent movie for 20 seconds. Thank you for listening to this silent movie. But the point is that this is a mother in Mumbai. This language here is Marathi, which is my mother tongue, so it is tremendously satisfying to see that our research is benefiting these mothers. In the remaining few minutes, I wanted to talk to you about the latest work that we've done. This is Kilkari, the largest maternal mobile health program in the world. So this is a Government of India program with India's Ministry of Health and Welfare. It serves 30 million beneficiaries. It has served 30 million beneficiaries total. There's 3 million active subscribers in this program. And Arman's task is to further scale up Kilkari all across India. The 5.28 crore audio messages that they talked about is more than 52 million. I have visited different sites within India where this program is administered, trying to understand the different constraints they operate under. But to this audience, perhaps most relevant is that we will not get any demographic features of these beneficiaries in this program at all. And so, in order to predict the next listening state, we have to do it without demographic features. And here we obviously turn to time series prediction. So here, for example, mother number 1 has listened to 30 seconds of the first week's audio message, more than 45 seconds of the second week's audio message, maybe less than 5 seconds of the last week's audio message, and then we are trying to predict how much listening she will do in the next week. Getting training data from the state of Odisha in India, we trained this model. So now we have different mothers who are represented as different arms of this time series restless banding using LSTMs. And now to select top K arms, we have defined a new index called time series arm ranking index. And so basically what is defined as the numerator here is for each beneficiary. If we intervene on this beneficiary using the method I, how long will it take for the beneficiary to drop below a listening threshold? Versus if we didn't intervene on the beneficiary, how long would it take for this beneficiary to drop below the listening threshold? So the higher the value, the more we want to intervene on this mother. We've run so far a simulation with 4,000 beneficiaries where we imagine here in the simulation we have 1% health worker interventions and 1% automated phone call interventions, and then look at how much listening would improve. And what we find is that with our time series arm ranking index, so there's two, the blue and the orange are with our time series arm ranking index, and the green is with the random interventions. We can see that time series arm ranking index would lead to higher amount of listening from these mothers. This is obviously being done in simulation. The question is what would happen in the field. So we are very excited that we hope to start a field study early January in health blocks in Odisha that have been identified, and will be one where we will do intervention with actual health workers. Beyond this collaboration, we've also collaborated with other nonprofits, for example, this HealthMum in Nigeria for AI-driven vaccination intervention. And this is work where we did the model, and we're fortunate to see that they have now deployed it in the city and shown that this leads to a higher amount of increasing vaccine uptake. That's their work. So with that, I'm going to end my presentation. Thank you for listening. Thank you.
Okay, that brings us to our final speaker of the morning series, Dr. Charles Delahunt, who is a senior research scientist on the ML team at Global Health Labs, an innovation and technology development group. He has over 10 years of experience applying ML to global health challenges, including projects on malaria diagnosis, vitamin A testing via pupillary videos, element of low detection, lung ultrasound, biometric sensor analysis, and pregnancy risk assessment. He has advised the WHO on automated digital microscopy for malaria, serves on the board for Rise with Kind, which works to increase participation of LMIC-based researchers in the ML community. I'm very excited to hear what Dr. Delahunt has to share with us today.
Great, well thanks so much for having me. I've actually reviewed for this conference for many years, but I've never been. I'm glad to be here, especially for this session, because as mentioned, my job is applying machine learning to global health. But with a twist, which is that at our lab, we're not allowed to work on a problem unless there's a very clearly defined healthcare use case that we're addressing. And we can clearly define what ML will do as a piece of that use case. And we can define a feasible path to deployment if we solve the ML piece. So that will shape everything that I say today, because that's kind of where I live. It's a very specific slice of the ML for healthcare world. And it is certainly the case, based on my experience, that ML has huge potential to help people in global health settings. Vast opportunity. The bad news is that we've kind of stacked the odds against ourselves as an ML community and made it very hard for us to succeed. And so my goal today is to, first of all, kind of sell you on the notion of working for global health. Secondly, explain where I think we're kind of going wrong structurally. And third, to give some ideas for how we can redirect. So first of all, why should you all drop everything and start working on global health? Okay, what's in it for me? And I'll focus on two things out of many. The first is that currently there is a shortage of trained healthcare workers in these geographies. And what that means is there is a shortage of medical decision-making ability, and that leads to a bottleneck, and there's a huge unmet need because of that bottleneck. So if any of you can come up with a tool that would provide trained medical decision-making that could be deployed at scale, then you could open that bottleneck and therefore meet a lot of that unmet need. So ML has a very unique value that it adds to this equation, and it's a whole untapped axis of opportunity. The second point I want to make is that in this space, it works. Like, focused effort pays. And the example I want to give here is the 2012 declaration on NTDs. NTDs are a grab bag of miseries. And a bunch of stakeholders got together and said, you know what, we can knock some of these back. And so they took some of the NTDs and put them in the declared group they're going to focus on, and some went into the undeclared group, which means, well, we can't do everything. And what you see on the x-axis are age bins, and each bin has two bars. The first bar is the accumulated total morbidity in 2012, okay, for the group of NTDs. And the next bar is the morbidity in 2020 after 8 years of focused effort. And green means life got better, and red means life got worse. And what we have here is we have focused effort and control group. And it's a demonstration that in this space, when a group of people get together with intention and say, you know, I don't know these kids, and I will probably never meet these kids, and they live thousands of miles away, but they matter, and their well-being matters, and we will take time to see what these problems are and try to address them. That really works. Okay, those green lines represent millions of kids who have better lives. So there's vast, vast potential here for ML in the global health space. But as I said, we've set ourselves up wrong to deliver on that potential. So to explain this, this is start with this, the famous innovation valley of death, which we may have come across. On the, I guess what side is this? The left, we have these, your left, the sunny sandbox where we do our proof of concepts, right? And we get to make the rules, we write our algorithms, and that's great. And then on the right, we have the clinic, where we absolutely do not make the rules, okay? And in the middle, we have this difficult path to the clinic. And at the best of times, this is a really hard path. And I certainly have a couple pet projects in the boneyard, and I'd like to think I did them well, but they looked great in the sandbox, and they bombed. The thing is that if we don't shape our algorithms from the very start to be ready for this journey and ready for that destination, then our chance of success effectively drops to zero. This is our experience. And unfortunately, I think the culture of machine learning, the machine learning community, is not adjusting our algorithms for this journey. And I think it comes down to the perfectly natural thing that we are specialists. And like all specialists, we have drilled ourselves a nice deep silo, or I think of it as a box that we're in. And that box is great because it allows us to specialize and focus and do really high quality work in a small area. But it's also a limitation because that box determines what is visible to us and it also determines what we can't see, and it determines how we approach our job. And the heartbreak here is that this ML box, which we kind of live in, this ML culture, kind of prevents us from seeing the very healthcare needs that we need to be working on to have impact. So to explain this, here on the left we have Daphne Kohler, who's done marvelous work in machine learning, and in machine learning for healthcare in particular. And she gave this wonderful interview a few years ago at ICLR. It's on YouTube, definitely watch it. And she spoke of many things, but one thing she addressed was why we have so few hits, why we have so many algorithms and so few clinical instantiations. And one thing she called out was our cultural, or ML cultural fascination with what she called mathematical gymnastics. Okay, and we just love stacking up the complexity and we reward that. And she says this is pernicious because, first of all, it doesn't bring us closer to the clinic. And secondly, it sucks all the oxygen out of the air because to publish a paper, you've got to do all that complexity, and it's pretty fun, right? And there's other reasons to do it as well, I mean industry reasons and business reasons. And so that's what we focus on. And I want to map that onto this two-dimensional grid we have here. And this is the two-dimensional space of ML work in healthcare, to succeed at healthcare. And the vertical axis, we all know exactly what it means, right? This is the ML sophistication thing. The x-axis is the work we do to be effective in the clinic. It's the work we do to ensure that this algorithm can work in the clinic and actually help sick people. And a crucial point here, the heat map is likelihood of helping a sick person, is that to first approximation, the clinic doesn't care about our sophistication. It just doesn't. And I've mapped down in the lower corner, ORT, oral replenishment therapy. That is for people who would die of dehydration because of diarrhea. And it's water, salt, sugar, drink. And it is the most powerful, most effective therapy of the late 20th century. And it's probably in the top 12 in the history of the human species, okay? So that's what healthcare cares about, is does it save people? Does it improve care? And the gray arrow is a typical, I'd say, machine learning paper in the healthcare space. It could be for this conference. And it has a fixed length, because we have a fixed amount of time and funding to work on a problem. And it points in some direction. It's going to explore some part of the space, right? And it's almost always vertical. And the reason it's almost always vertical, going back to Kohler, is that peer review is a very strong, powerful, what is it, the worst of all systems except for every other that's been tried, right? And it is a very powerful positive reinforcement mechanism to keep doing what we're doing. And so we reward what we recognize, and we recognize this y-axis. And so peer review effectively becomes a dot product against that y-axis, which means if your work is in this x-axis, then it will not show up at the conference. So we don't discuss it, it doesn't get into papers. And so I want to talk more about this x-axis here to kind of explain what we found it is. So the background for this figure is that I was complaining to my neighbor about how hard it is to make AI stick in the clinic, how it's just so hard. And he's a doc, and he's worked for many, many years in Kenya, at women's health clinics and HIV research and vaccine trials and kind of doctory stuff like that. And he says, yeah, there's just a lot of pieces and they've all got to interlock for things to work. And that's what you see on the left here, that there's a healthcare solution, which is the whole jigsaw, and there's an ML piece in there, and there's a lot of other pieces that are not ML pieces. And you'll notice that the ML piece has a funny shape because by definition it has to interlock to have a system that works. And those red arrows represent pressures on the ML algorithm that will shape it so that it works within that healthcare use case with those non-ML factors. On the right, we have a more standard ML development program where we are building a solution and it's being shaped by forces, those red arrows. But those red arrows are all within our box, okay? They are things that we are used to, like having lots of math and having the latest and greatest algorithms and having a comparison with other methods, even if the metrics have no bearing on on the healthcare use case. You gotta have that comparison of the ML bake-off board, Nsoesie called it once. And so this is the y-axis on the right, okay? And it's a valuable thing, and it's what we need to do. The problem with this is that it creates a round solution to fit into a jigsaw-shaped hole, okay? And that will not work. So that's the result of kind of dot producting onto the y-axis, that's what we always end up doing. We kind of have a one-dimensional view of how to solve this problem. The jigsaw, those arrows in the jigsaw represent the ML work that's done on the x-axis, moving toward the healthcare, toward the clinic. And I want to say three things about these. First of all, they are ML tasks. They are technical ML tasks because the clinician can tell us what their performance requirements are, what their constraints are, what data is available, whether they have electricity at the clinic, or internet or whatever. But it's our job to translate those constraints into something that can shape an ML algorithm. By definition, that is ML work. And it's very difficult work, it's technical work. The second point is, it is vital. It is a necessary condition of getting something into the clinic. And the third point falls from the first two. If this is technical ML work and it is necessary to success, then we need to be sharing that information. We need to be publishing papers and highlighting at conferences and exchanging among ourselves what works and what doesn't. Because otherwise, we won't get over to the clinic. So at the bottom, that quote pretty much covers why we seem to stay on the y-axis, which is that that's where our incentives go, right? And we all follow our incentives. And so our incentives are pointing toward this y-axis, but the clinic is over here. And so the question is, how can we shift over a little bit to do the two-dimensional work, if you like, to reach the clinic? So to address this, I want to refer to this conference's call for papers, or rather the statement of excellence for a paper in this conference. And if you look at it, there it is. It's a two-parter. And if you study it for a second, you realize this is exactly right. It's a two-parter. The first part covers the y-axis, okay? The ML sophistication, the ML-centric part of our work. The second part articulates the x-axis, the effectiveness for healthcare that will get us closer to the clinic. And so this is a great high-level statement of what constitutes an excellent paper. The catch is, the drawback is that we don't actually know what the second piece means, I think, based on our experience. Because we never see it. We don't see it in papers because it never gets published, right? Because of that dot product effect. And so it's not concrete. And so, for example, when we show up at the office, we don't say, yes, well, I know exactly how to work on this effectiveness part, because we're not familiar with it. Or if we're reviewing papers, we don't know how to assess a paper based on effectiveness. So what does that mean, right? It's just like shooting in the dark. So we revert to what we absolutely know, which we imbibe with our mother's milk, which is this ML sophistication part. So we end up on the ML axis. And so what I want to do here is offer a checklist to make this highlighted part, the second part, real, okay? And to make it concrete. And you could use this, for example, if you're researching a project or if you're reviewing a paper. It's like a checklist. And it all comes down to truly understanding the ML use case and how, the healthcare use case, I'm sorry, and how our ML is going to fit into that. Because and this is more than just saying, yeah, ECGs are important for heart, and so we're going to study ECGs. No, it's really understanding that use case. And for example, are we reading and citing non-machine learning documents, right? These healthcare problems existed long before ML existed, and they have a huge literature and a huge life outside of ML. If we're not reading those documents, then we don't know what the problem is. And if we're not sharing those in our papers, then we're not helping other people understand the problem. And the question of ground truth and data and labels, ground truth is incredibly complex and nuanced, and even clinicians often don't know what ground truth is for a given case. And So just shaping the data and the labels, just figuring out what the ground truth is and shaping that data is a really hard task. It's a highly technical task, and it's a task that makes or breaks the whole project before you ever press go on a training run. So it's something we need to be working together to figure out. Do we give clinical performance requirements? And this is important because clinical requirements are brutal. They are much harder, I would argue, than doing an ML comparison with another algorithm. And we need to know what they are because we're not going to hit them the first few times we try, but we need to know where we're headed, okay? And we need to articulate what pitfalls and what shortcuts make life especially hard or especially easy in this use case, because we need all the help we can get to reach these hard targets, these difficult targets. And we need to be using the relevant metrics. So in ML, we have to use metrics to evaluate, both to guide our algorithm development, but to evaluate, are we on the right track? And there's a lot of generic ML-centric metrics we use, but the clinical use case has some other metric it needs. And so we need to direct our metrics in that direction to know if we're making progress. And we need to report meaningful evidence. And I want to direct you to this a WHO paper, it's a document, a wonderful document, came out 2021. And the idea here is that we have the trajectory from the sandbox to the clinic is a very tough trajectory. And a method has to be supported at every step by appropriate evidence to make that journey successfully. And if at any point the evidence isn't there to support the next step, game over and we drop like a rock. And the catch is that we don't get to say what the evidence is. This is a healthcare application, and healthcare runs the tables. So we have to understand what kind of evidence supports, in the healthcare context, this algorithm moving forward. So, and the nice thing about this document too is that the last couple sections are about late stage, like clinical trials and late regulatory and devices, which we don't normally deal with, so you only have to read half of it, right, the first half. And if you want to see a concrete example of this, you can check out this paper. It's on archive now in review. But it walks through this checklist for the case of malaria. So you can see, okay, this is, if we were doing malaria, this is what we mean. This last note at the bottom is, because all this at the top is about articulating and clarifying and making space for this x-axis, the effectiveness in healthcare axis of the machine learning work, so that we have a truly two-dimensional space that we're working in and exploring and sharing. And an applied track is a way of giving space to that. It's, I think ACM Jill does that, Mika has a version of that. But Timnit Gabriel made an interesting observation that it has to have, the applied tracks are great, they have to have equal status to the theory track, because if the theory people are flying first class and the applied people are back with the luggage, then we have the same incentive structure that we have now. Okay, and so, well, I'm going to give you the gift of time. So this covers it. I think the whole point is that what we found over the years is that the space of providing machine learning to actually help sick people is a two-dimensional space. It's not just the ML-centric axis, it's this whole other axis that doesn't get enough effort and exposure and clarity. And for me, this comes down, you can kind of, for me, encompass in 4 characters, which would be ML4H. And by that, I mean machine learning as a servant for healthcare. And the last thing I want to remind you is that this kid, this exact kid, is the kid who will gain or lose or have a better or worse life according to how we choose to deploy our time and resources and skills. So no pressure at all. But thank you so much.
Okay, let's have another round of applause. So next up we have our panel with 4 speakers in the morning series. Is this not on?
How are
So we will get ready for the panel, which will be moderated by Mercy. So I'll hand this off to her. And maybe after we get set up, the speakers can come up. Thank you.
Hi everyone. That's a really fantastic talk. Thanks so much to listen to us. I'm Nsoesie. I'm a program chair for this conference, and I'm also a research scientist doing research. Alright. My work focuses on machine learning for global health applications and health ecosystems. Sorry, I was just kind of running back and forth, so a little out of breath. But why is this important? And the speakers can come up as speakers will. So machine learning, generative AI, foundational models are changing the world and are already demonstrating how they can improve how healthcare is delivered. From reducing physician load by assisting in administrative tasks like interactive medical note-taking, radiology reports, classifying and correcting for health inequities, as we just heard from both Elaine and Emma. And let's not forget, passing the United States medical licensing exam with flying colors. Globally, forecasting models that was a joke, by the way. Globally, forecasting models have been used to predict COVID outbreaks during the pandemic and are being used to guide malnutrition mitigation efforts, assist community health workers in rural areas to deliver care, and as we heard from Milind, identifying key beneficiaries for educational text messages for maternal health. A lot of countries around the world are just beginning to catch up with deep learning models and neural networks. And already in the US, we are onto the next big thing, generative AI. Now, while there are undeniably positive implications for AI, we also acknowledge that it comes along with potential risks. We see disparities in health and a large percentage of, in the US at least, minorities who mistrust the health system. Machine learning systems could potentially further widen disparities, with these models being shown to perpetrate pre-existing biases or underperforming for underrepresented patient subgroups. In global health, these biases may perpetrate in a similar way, but there is very little work thus far to understand fairness and bias in these systems. Additionally, the speed and high cost at which foundation models, for instance, are being developed runs the risk of leaving lower and middle income countries behind in AI-enabled technological advances for health, which could further widen disparities. For these tools to really be beneficial for everyone, there's a clear need to have conversations like this one in venues such as ML4H. And as Charles mentioned, we need to navigate the balance between technical novelty and real-world clinical impact, starting from identifying fair health needs. I am so excited by the work of our incredible expert panelists, and I look forward to hearing more from them and also to hearing the questions that you have. Now, I will start with just a few pre-prepared general questions because I know everyone is also dying to ask questions. So I'll limit this to about 2 or 3, and then we open it up to the audience. And I just encourage our panelists to be concise in responses so we can answer as many questions as possible. So the first question, every time I see people doing amazing work, I like to know what motivates them. Why did you choose to focus on this area of everything you could work in, quality, health equity, and global health?
Yes, I can answer quickly. It's pure chance because I stumbled into a job where I started working on malaria. And this is one of those things where you cannot unsee things once you see them. And once you're in this space, you realize how incredibly unfair it is, how much unmet need there is, and it just has its own energy moving forward.
I was born in Cameroon, and so I grew up aware of health disparities. Both my parents are in healthcare, so I have been interested in health disparities for a while. But interestingly, in undergrad, I tried to run away from public health, to stay as far away from my parents as possible. But somehow I ended up in the same place as I learned more about public health and about how I could use math, which is what I was studying. I studied in undergrad and how I could impact public health, and then I'm coming back to work on this.
I became interested in health because of my family's history of cancer due to a genetic mutation that I myself inherited. I became interested in health equity because I was working at a genetics company, 23andMe, and I would reliably see these like massive coefficients on like gender, race, or age, and like these tiny, tiny little coefficients on most genetic variants. And as I wrote to offend at the time, I sort of reluctantly became a feminist statistician because it was just clear that like the big betas, the big coefficients were on, you know, these basic, you know, determinants of the.
My research group and I have been focused on AI for society for decades, and the last 10 years or so previously had been with, working with youth experiencing homelessness in Los Angeles and HIV prevention. There's always this desire to see how research could impact the city that I'd grown up in Mumbai, in India. And so when the opportunity presented itself with the meeting of Dr. Marinka, which was by chance, but I realized that this was a massive opportunity for now to contribute to that city. And so that's what motivated me.
So my next question is, outside of your own work, is there one notable contribution that you have seen of machine learning to either health equity or global health applications outside of the work? And why do you pick this specific one?
Yeah, I heard a great talk at ML4H 2023 about some work in India where they were using fairly sophisticated machine learning models to increase uptake of messages for maternal health care. And I thought this was wonderful because it is actually being deployed, right? And so somehow they cracked that puzzle of using complex models, and these models were probably as complex as they needed to be, because sometimes it's easy and sometimes it's hard. And so I think that's a great example of hitting it out of the park.
I think I like two examples, but they're from the same community. So there's a nonprofit organization called Data Science Africa, and its focus is on developing capacity in machine learning and data science across the continent. And there are amazing researchers with them communicating doing a lot of work. And two examples. One of them is focused on air pollution monitoring across cities in Africa, and the website is called Agrawal, for those who might be interested, and they're doing a lot of amazing work. And then there's another example is focused on reducing school dropouts for girls. So we developed this machine learning algorithms that work with communities. So they developed in collaboration with communities to make sure it's actually being used to reduce dropout rates for girls.
I can name the paper that sort of got me very interested in AI for health, which was, I just, got some of that genetic news, and I saw this paper from Daphne Kohler, who, was name checked earlier, on using features in breast cancer histological slides to predict survival, and basically showing that like we can contribute to medical knowledge because features that no one had thought were important to impact were quite predictive of survival. This was not specifically a health equity paper, but it was certainly inspirational to me, and I think the same idea of using machine learning to enhance our understanding of health problems with an eye, particularly to underserved populations, has certainly been part of my work since then.
So I wanted to continue this tradition and say, I'll mention two pieces of work. One was the talk I just saw at ML4H right now from our distinguished speaker here, Emma, and so I'll mention the work there. So thank you for that. But there's also the this work from Harvard Data Science Institute, don't remember the exact authors, but this is about pollution, capability, and things like that. The impact that they've had on policy in trying to prevent such pollution, and especially impacting different ethnic groups and so forth. And so I feel like that was very inspiring to see that they have actually impacted policy in terms of reducing pollution. So unfortunately, I don't remember the exact author names right now. Yeah.
I think I might actually. Yeah, it works. Right? Okay, great. And then the next question I have is, so what strategies do you think need to be promoted for inclusive and co-development of ML solutions to meet specific needs of diverse populations? And how can we involve relevant stakeholders, especially when they are far removed from the process itself?
So for us, it's always been about partnerships from beginning to end, whether it's with youth experiencing homelessness, which means with homeless shelters, with different social work organizations, or when it was working with conservation, it's with conservation agencies on the ground in national parks and so forth. So that beginning from the problem statement all the way to developing solutions, to testing them in the field, that has to be key. And at any point, they can just point out some of the things that they're thinking about that are ridiculous. And I agree with the point that was made earlier. That sometimes, we can get beautiful theorems if only the real world would just slightly change to our needs, but that's not the way things work.
I think a lot of it is about sort of changing the incentives we have as academics. I think, this talk about how we're strongly incentivized to have like a vector like pointing upward very much resonates with me. I gave a talk at an event a few months ago, and I was told I was not doing rocket science, I was doing poor people science, which so I think changing the incentives we have around publication, changing the kind of work we think of as high value, recognizing the incredible difficulty of coming up with deployment end-to-end, like I'm in awe of the ability to do this. I think that will do a lot to change the kind of work that we're publishing and incentivizing these kind of participatory collaborations.
I think my thoughts are the same as already been shared. Engaging with communities, I think Charles talked about how to get from developing a model to getting them to work in clinics. I think the same way, whether it doesn't matter what problem you're trying to solve, thinking about who's actually going to use the solutions you're developing. So it's a particular community, how do you engage with that community from the start to make sure that whatever you develop is actually effective and useful.
Yeah, and so I will be the third person to say that same thing, that it really comes down to having partnerships with groups who are close to the problem, because all these problems are local. And so it really is getting out of our box and recognizing that we are one small piece and all these other players really are the ones who understand what needs to happen.
We have about 33 minutes more. I have a few individual questions, but I will open it up to the audience now, and if we run out, yes, somehow. But I already see hands up.
Yeah, I can come to you with a mic, so if you raise your hands, I'll come visit.
That's a gentleman, I think, who has raised his hand first.
The four fantastic talks, like great job with the organizers. That was amazing. Every single one of them rang true for me. And I'd love actually maybe you could talk a little bit more, because I think this audience would benefit a lot more from hearing more about what meaningful partnerships are about. Because I kind of have a particular background, I think very aligned with many of you, but I've seen a lot of partnerships between machine learning folks and health code folks. But the partnerships amounts to the machine learning folks saying, hey, healthcare people, give us your data. And then they go away and they work on a little microscopic technical problem where they eke out in the 0.02 extra AUC and they publish that paper and then we move on. And they've done nothing to address real clinical problems. So maybe you could talk deeper about what for you have been successful partnerships, what are the ingredients to success, how do you work with clinicians effectively, because I think that may really help that.
Yeah, I can certainly go on for 33 minutes about that. First, your point about the point to AUC. This is something now I realize I forgot. This is what peer review is all about, right? I forgot to put this in the talk. We can find differences with a small p-value, but there's also the difference that will be meaningful clinically. Okay, so that's another thing where you have to measure, are we really clinically improving, or are we just finding a slightly better AUC, 2% better than the previous? So partnerships, so I'm very, very spoiled because I work in an organization that is funded by Bill Gates, and that name seems to open a lot of doors. And we work with the Gates Foundation, so we have access to a wide network, worldwide network of collaborators. And all our work starts with a partner who knows the problem. And for example, when we worked on malaria, we were trying to do diagnosis of blood films. We were able to assemble a technical advisory panel, which were leading people who ran malaria clinics throughout the world. And they came, we invited them over, and I was able to ask each of them, like interview each of them for an hour, like what matters here? And we had a full day, 2 days of meetings. What needs to happen? What matters? What doesn't matter? What does this algorithm have to do? So those experts who were clinical experts made a huge difference. Another case is I'll give for cervical cancer, and this is an interesting one because it's the many layers of collaboration. We wanted to do cervical cancer algorithms. We were working with an OB who had gone to Zambia to work on it. He had found that he needed to work with the local hospitals because they understood the problem of cervical cancer in Zambia. Then they needed to work with the rural areas, the healthcare clinics in the rural areas. It turns out that they needed to work with the leaders of each village, the men and women who kind of help the village make decisions. It turns out they had to work with the nurses who provide the care. And even then, it turns out that they had to draw on women in the community who had experienced cervical cancer or lived or lost people to it. Because all those levels were vital to actually getting a solution at scale. And so we were like 5 or 6 levels removed from the people that had to really deliver the results. And it really brought home to me how, in a way, how small the machine learning piece is. I mean, it's very important, but all these other players are so much more powerful when it comes to really getting a solution.
Just to add a tiny bit to what Chelsea said, I think it's important for us to redefine how we think of expert, because we tend to think of ourselves as the expert, but depending on what problem we're trying to solve, there are so many people who have expertise in different aspects of that problem, including the people who are in particular communities that are being impacted.
Yeah, I definitely agree with that. In particular, if we could stop privileging like mathematical expertise above all else, like that would be great, I think. One thing I do want to say is, beyond sort of tips for individual people, I think we as a community should be thinking about how we can facilitate this kind of matchmaking, because I think there's real hunger for it on our side. So I don't know if it's like, maybe we could have like a matchmaking session in a future version of this event, or maybe there's like a platform we could use to facilitate this matchmaking, but like, I feel like there's real hunger on both sides, but it like can be quite hard to do in practice, so like how can we create events that facilitate that systemically? I think quite interesting.
All of what was said, I agree with. Humility is crucial. I have a lecture on building partnership in my class on AI for social impact that I teach, and so I have a lot to say. But visiting the actual location of the partner is important. But going to the point about matchmaking, we have been running these matchmaking sessions out of Google AI for Social Good. Hopefully it will run in the future as well. So we invite nonprofits to apply and also researchers to apply. And then there's speed dating of having each nonprofit meet with 3 researchers and each researcher meet with 3 nonprofits and they write proposals, and for successful proposals, there's a small amount of funding to go and produce good research and then follow through funding if that tends to work. So I'm hoping that we can push this forward, but hopefully that might be one that.
So this concept of expert, yeah, let me just iterate that absolutely, but in our experience, we are absolutely not the experts for these healthcare problems. But one way we can think of ourselves that's glamorous enough is that we are surgeons, right? Surgeons have highly, very difficult technical skills that are incredibly valuable in a context. But surgeons don't run out in the street and grab people for spleen transplants, right? They work within a context where they can use their skills in a directed way under the advisement of others and with the patient. And so I think that's a good way to think of what status our expertise has in this context.
I also want to say, there's so much to say, but I'll stop on this. I think also the ability to walk out of a partnership with AI is machine learning is really not the solution. So we've been in a different context of conservation. A national park where a minister at a higher level will say, yeah, we want AI, machine learning, whatever, high tech to be used. And you go talk to the raters on the ground and say, we just need better shoes. We don't need any high tech. And so in those cases, it's better to walk off. And so that also is the key. So thank you for that question. I'll stop talking about this.
So it sounds like redefining who the expert is and what expertise means, humility, and potentially exploring matchmaking avenues and recognizing that AI is not a solution. Thank you so much for your responses. Any other?
One more question.
I would like to echo what the first one said. This is really an outstanding panel, outstanding work, and also very inspiring. Thank you all very much. I do have a technical question. I hope that's okay. So I have a question for Dr. Pierson. So you mentioned we hope to predict what are the target, the actual target, right? And one example you gave is we can leverage covariance shift assumption. Related to this, and also we can generalize the question a bit, is, well, how do we validate whether this assumption holds in a particular situation or not? Thank you.
I mean, I'm tempted to make Divya answer this question because it's actually her all right, okay, fine. Yeah, I mean, it's a great question. I will say more broadly, on these sorts of missing data problems, I think a central challenge is like, sure, you can infer whatever, but how do you know if what you infer is actually right? And I think that's like a basic evaluative challenge and arguably one of the hardest things in doing this work, and I can talk about this a lot. In that specific paper, it's so nerve-wracking to talk about a paper from the first author is actually there. This is what you made me do. We do a number of things. One is that like we show robustness to a plausible violation of that assumption. So the covariance shift assumption probably doesn't perfectly hold, and we show that like our method is still applicable even in instances when it doesn't. We also, I think, give two validations. Basically, the model we're fitting is a restricted class of models, and we propose two validations for like whether that restricted class is actually an appropriate fit to the data. So those are two things we do. And for full details, I would refer you either to Divya or to the paper itself.
One more question.
Thank you. First, I want to say thanks a lot for invigorating series of presentations. And this is more a little bit of a commentary than a question. I have a background in entrepreneurship, so I run the AI portfolio of Australia's largest investment fund and incubator digital health for the last couple of years. I'm just delighted that we have this discussion, and specifically, Charles, when you mentioned like your bullet point list of how to check whether machine learning has a role to play in a pitch is like spot on. So this is really often the overseen. Very often we see that founders throw a solution over the fence, think that if they sugarcoat AI over it, it'll stick and it will return millions. And it's just not that, right? So what I wanted to add is to your two dimensions, there is also a sustainability and business case angle to this, right? You might still have a solution that fits the problem in the real world very well. Machine learning plays a role for it, but it's not a self-fulfilling prophecy, right? So there is that dimension to getting an idea out into the real world that also looks into whether this is actually a sustainable solution, whether there's a funding model there for this, whether this is something that can be contained and supported. So I think what you all said is spot on. There's just maybe this little bit on top of it that also thinks about the commercial relevance impact and aspects of bringing a solution out there, which matters whether it's successful or not. And that's just something that we need to take into account as well. But otherwise, spot on. Thanks a lot for bringing these points out there.
Yeah, no, I agree. And actually, my picture, one of the puzzles was business needs. And so, you know the rush to nesting dolls, where you open a doll and there's another doll inside, you open that one, there's another doll inside. What we found is that the machine learning for global health or global health solutions is just like that. You have your machine learning and you kind of solve that, you open it up and there's an even bigger doll inside, which is validation. You open that, there's an even bigger doll inside, which is trying to get a test in the field. An even bigger doll inside, which is like a sustainable business case. And the dolls just keep getting bigger. And in a way, it's kind of overwhelming in a sense that all these other pieces are so hard. And that exact piece you mentioned is one of the hardest, yeah. But we still have to do what we can, right? There you go.
Yeah, I have, was someone going to? I do have a question for Elaine on some of the geospatial work that you've done with trying to identify neighborhoods and inequalities in neighborhoods. So could you talk a bit more about how, I guess, why data sets that are kind of obviously, like, I guess to a layman, kind of removed from the actual incidence rate of the actual health outcome or measure. So why do you use these data sets and how are they generalizable beyond places like the US, which may have better measuring capabilities?
So a lot of the data that we use, or at least the indicators that I focused on around social determinants of health. And there's a lot of public health research that has shown that these factors do contribute to health outcomes very significantly, not just in the US, but across the world. But the factors might be a bit different depending on where you are. What is most important for one country might not be as important in another country. So transferring the methods would depend on what are the questions that we're trying to answer in a particular context, and is the data that we're using the right data set, or are there other data sets that would better answer that question?
We have one more question from the audience.
Thanks for the great talks and the panel. I'm the president of Simplify Networks, a nonprofit based in Seattle, pushing for open science in the biomedical sciences. One of the things we do is running open challenges, kind of like Apple competition, but for biomedical sciences. And we've found that when you create that open challenge and you bring clinicians at the table in such a way to work with them to encode that target metric, and then the community has to, try to optimize with submitting machine learning models. That is a way to create aligned incentives by default, by definition, right? They get embedded in the problem. And then you're not really good at the technical sophistication piece, just like go to town with it, but the constraints that were defined by a clinical effectiveness framework. How are you thinking about like this open benchmarking as one of the potential avenues to kind of like align incentives, or at least in that vector space that you were showing, go more in the direction of clinical effectiveness?
So I'm sorry, you're saying what specific data sets or?
Yeah, finding a specific data set is the first step, but not only that is liked by machine learning people, but it's also liked by folks that have clinical expertise. And B, defining a task to optimize as part of the data challenge. An example is a data set of mammography, and the data challenge could be identify presence of breast cancer. In fact, this is a challenge that we ran in 2017, and on the top 18, the score with the highest scoring algorithms, 6 years later, 2 of them got FDA clearance for algorithms. So direct translation impact there.
So it's your question about having more of these types
Yeah, do you see that as an avenue to align incentives?
Yeah, I got it, yeah. And absolutely, because I think what you do then, it's a structural solution, right? Because these are structural problems. And so what you do by doing that, by getting the clinical experts in to define a target variable, as you know, that is appropriate to the clinical use case, then we are all just forced. We naturally go for the right target. And so I absolutely agree that that's the way to go. And actually, for example, we're hoping to release a malaria data set and structuring it very carefully and setting up the desiderata very carefully to match what is necessary in the clinic for malaria diagnosis for the use cases. So I totally agree that that is a way to structurally bake in the guardrails so that we go the right direction. Yeah.
And I've seen some more work from Global Health Watch that has released several cancer data sets, but I'd love Elaine and Emma to also talk more about kind of these bias, if there are any such data sets for looking at biases and social determinants of health as well.
Well, I got something else I wanted to say. Okay. I just want to, I think this is a great idea. I wanted to give a quick shout out to the folks at Nightingale Open Sciencers who have set up a similar sort of, data sets that are easy to get access to. They're standardized prediction tests that actually, tasks that actually make sense in a clinical setting. And I do think work along this line, like pointing us, machine learning people in the right direction of actually solving the problems is very fun. Yeah, Nightingale Open Science, yeah. Oh, sorry, okay.
Question, so bias in...
So for instance, some of the work on social determinants of health, like to what degree are there structured benchmarking and, for instance, cargo competitions around those data sets that people can kind of play with?
I can't think of any. I don't know any in that sense. I do know that there are people who are working around some of these newer data sets that we're using, things like satellite images, to better understand what the issues around the data. What does the coverage looks like? What is the data quality for different places? And how can you use it more equitably in the research that we're doing?
I think it's certainly an excellent idea, but here I feel you are doing some very hard work to identify actual problems and then distilling it to the finest point of, okay, this is the problem to solve and so forth. And that's important. But perhaps there's another competition idea, if you will, where there are nonprofits who are working in terms of global health, not in the developing world, but here too, whether it's youth experiencing homelessness or others. And one of the challenges is really just trying to understand where are the opportunities for machine learning to make a difference. And it's not necessary that there's a ready-made data set, but where in many of these domains really lack of data is a problem. And the research is actually how to deal with the fact that there is no data. And the PhD theses are really in how do you deal with the lack of data. And so perhaps one idea of a competition is to have people figure out sort of the most innovative, if you will, challenge from a nonprofit sector or some of the government sector, etc., whereby perhaps there's a lack of data, but there's a very innovative machine learning problem that came out of it.
I'm really glad you answered. I was just going to ask you the question as well about data paucity and countries that might not have quite as good data storage processes in health.
We have one more question back here.
I have a related question to the one that just was asked, where Dr. Tambe, you mentioned sort of some experience you had where kind of accuracy on a benchmark was not correlated with sort of the intervention effectiveness. And I think that happens in many clinical situations where even if you're improving accuracy of your model, it's either a negative signal or sort of a neutral signal when it comes to actual clinical utility. I think Charles, you mentioned that in your talk as well. And so I'm curious about, just the characteristics of those situations where improving accuracy is not correlated, and sort of sort of the clues that you've picked up over the years of when that discrepancy occurs?
It's an excellent question and an active area of research to try to sort of zero in on where this problem arises. But clearly, this is something that we've noticed repeatedly, that if there is this predict then optimize structure where at first you're just predicting, what ends up happening is that you're trying to improve prediction accuracy on average across all cases, but your intervention resources are limited. And so you really can't act on all of these cases. And so you really have to focus more on the cases that you could actually intervene on. And so what this decision-focused learning, smart predict and optimize techniques are trying to do is to zoom in on exactly those cases where intervention would matter and try to improve your prediction accuracy only on those. So it appears at least one area where this would matter is where your intervention resources are limited, and so you have to really be precise about where you want to intervene. But it's a very interesting area because I don't think we have a very good characterization where these decision-focused learning approaches really work.
Yeah, so I'm going to highlight one particular aspect of that, which is that and actually it's what you mentioned, the population. Models can do better on the whole population. We look at the whole learning loss, let's say, but the populations don't walk into the clinic all at once, right? They're not diagnosed. Well, some applications you diagnose on the population level, but usually it's a single patient coming in. And so, and to be useful for diagnosis, an algorithm needs to not be better on the population level, because it's easy to separate two distributions, with a p-value, but it has to be a large enough distinction to distinguish for an individual. And that's a core distinction between clinically useful prediction and statistically significant prediction. And I'll just give an example from cervical cancer of the other point you mentioned of finding the right target, I think, which is that in early cervical cancer work, we were trying to improve diagnosis, and our ground truth, what we were comparing to, our gold standard was visual examination of a cervical vinegar application. And it just didn't work, And then we changed our ground truth to be histological positive slides. So we had some patients who, whatever their examination said, they were histologically positive for cervical cancer. And that turned out to be the key that opened up an effective algorithm because it was the effective ground truth. So this is a crucial point. Yeah.
That was part of my PhD thesis, so I second that. Any other questions?
We have one more right here.
So I was going to ask Charles and the rest of the panel. Charles, you mentioned the Russian doll analogy, and hidden within the commercialization is the regulation aspect. And I'm wondering to what extent we can turn this potential landmine. We're finding it's more and more difficult to get AI type algorithms through the FDA and other regulatory bodies at the moment, and for good reason, but also it's increasing the barrier for us and creating a new landmine. And the lack of regulation or coherence between regulations between different countries is just yet another barrier to us. But I'm wondering whether the panel has any thoughts on how we can flip that, and through these international competitions and public data sets, potentially create standards for machine learning and how it can cross borders.
Comments, but do you have any comments? Not sure I understand.
So I believe the question was around whether there could be cross-country collaborations through these computations to create some kind of standards that span international boundaries.
Yeah, I think I got the question, Gary. So first of all, a couple documents. That WHO document is really talking about every step of validation of an ML AI algorithm, all the way, including regulations. So if you read section 5, it'll be the regulation. So that's a help. The FDA is working on, you may be aware, on new guidelines. They're trying to absorb what do we do about all this AI stuff, and so they are developing that. I think that there's a scattered regulatory landscape over countries. Many look to the FDA for guidance, but again, here, another reason to work on global health, people. In some of these geographies with global health, they have different regulatory, and they're more willing to try stuff. The US market is so locked up, it's really hard to get anything done, but some of these other geographies, they've got problems and they're willing to try things if there's credible evidence that they'll work. And so one way around it, I don't think we'll get international cosmic agreement. That hasn't happened for the past 400,000 years, so I'm not looking for it now. But I think certainly there are geographies where life is easier, where there's more likelihood that things can get deployed. And once they're deployed, I'll give you an example, a very quick example. A friendship bench. This was something in Zimbabwe that was developed, and it's a bench outside a clinic, and they put trained local, just people sitting there. They called them grandmothers in the original study, to sit and talk with clients who come in and out of the clinic. And they found improved outcomes. It was a very popular thing, and it improved the outcomes of patients. And there's like 70 of them in Zimbabwe because they said, hey, it works, let's do it. And someone at Johns Hopkins said, this is great, let's put one outside a clinic in Baltimore. And 3 years later, she's still trying to get a bench put outside a clinic in the United States. And she's a lawyer, and she still can't do it. So the upshot to your question is, let's go to these geographies that have global health issues because they're often more amenable to deployment in any case.
Yeah. Sorry, we're going to continue with questions. I'll go here.
Thank you very much. My name is Jerry John from the Responsible AI Lab here in UST Ghana. I'm listening and I find the conversation very exciting, and I just want to put this in perspective. Where there is an intervention and the intervention is seen to work, we are looking at this in the context of, if we say it works, does it work for all manner of persons? So for instance, if a drug is seen to be efficacious, definitely, if it has approval, all manner of persons it works for. But in this context where we apply machine learning to global health, for instance, we definitely need to train our models with certain data sets and all that. So if we have trained it using data sets from a certain category of persons, and we say that it works, are we able to stretch it such that we say it works for all manner of persons? And I'm looking at it in the context of, if you train your models on data sets that have been gathered in, for instance, the global north, and a significant percentage of people from the global south having been taken into consideration, do we say that it works for all manner of persons? And where that is not the case, what intervention do we put in place to ensure that we are able to correct the problems that we have?
That's a great question.
I can start. I think a good starting point is the data. So if we're trying to train what the machine learning solution is, we're trying to train in a way that works for everyone. We need to make sure the data is also capturing the population that we want to do that for. And then the second thing I think is important is defining what works means. Right? When we say something is working, do we mean it's working for a specific population, or do we mean it works across all populations? So by defining that, I think also that impacts how we measure things like accuracy, how we measure things like the performance of the model, how we talk about equity, how equitable the model is, and so forth.
Yeah, I very much agree with all that. I think also it's about recognizing the limits of distribution shift methods, which are designed to deal with these sorts of issues, right? Like there's a limit to how well a machine learning algorithm is going to generalize to populations who are fundamentally underrepresented in its data set. And while that is an active and an important area of work, I do think, a core part of this has to be fixing and improving the data sets that we're training these models on in the first place.
It's a very interesting question, an important question. Certainly in the context that I presented in my work in India, for example, the fault lines are different. It's not race, it's caste and religion, for example, for which, as I showed, there is no data available to us, demographic data from the national program, and even for the regional program, the nonprofit intentionally does not collect this data just because of safety constraints and so on so forth that they have. And so then the question becomes, how do you ensure exactly this, equity across all these different groups when you don't have the actual demographic data to work with? That's a very challenging problem. And so then do you triangulate from other covariates just in case you have them? So we've tried to do that by looking at other indicators of marginalization. So we work with populations that are already, as I said, 95% of them are below international poverty line. But even within that, there's further marginalization based on, say, low income or low education. And so those could perhaps be indicators of further understanding of whether that, are serving those populations. But in general, it becomes a very challenging problem because there's just not that kind of data available, and it's very, very important to figure out how do we address these challenges.
Yeah, I actually don't have any answers for you. You have pointed right to one of the very biggest Russian dolls in the whole stack, and it's just really hard. And it feeds into the regulatory question because to get regulatory approval, you need to show that you can shift across different distributions, and that's really hard. Although at ML4H 2023, there's going to be a generative AI session, and that is a potential way to quickly shift models to new geographies, so helping with that data shift. So that's potentially a really great session if you have time to go see that in New Orleans 2022.
Right here. So yeah, and I just wanted to add that's a super nascent area of research, looking at distribution shifts and what kind of shifts we should be looking at outside of context beyond the US and the context of the West, and it's something that I'm super interested in as well. So definitely encourage anyone who is interested in this area of research to look into it.
We have two more questions from the audience if we have time.
Hi, thank you so much for the talk. I'm a physician, so listening to this is very interesting because I heard a lot about systems and a lot about large data sets, but not too much about the provider-patient sort of relationship. And that's really where the rubber meets the road, where you take a technological product, you apply it in a humanistic way to a patient, and you're seeing that. So with that context, I'm really interested in the idea of picking the target variable that you want to predict, because in a lot of these indications, there's just one target variable that we look at, which is usually some sort of cancer diagnosis or some sort of prognostic risk. But in a lot of these interactions, it's not so clear, right? You have different target variables that you're interested in, and then you engage in a process of shared decision-making with the patient, where yes, you could decrease the mortality by 2% over the next 6 months, but they want to spend more time with their family, right? And they want to increase quality of life. So when you see them in an emergency room and you try and talk to them, those two target variables are extremely relevant for that patient to whether or not they come in, seek care. And I wonder how you think about that balancing. How do we take into account multiple target variables that reflect different preferences?
Yeah, no, this is a super good point. And there are two things I would say. First of all, one option that we lean on more and more heavily, I think, is the notion that ML can provide information to a provider. ML does not provide the diagnosis. You don't press a button and say, okay, this is what should happen to the person. You press a button and say, based on what we know, here's information that the physician or the caregiver takes into account. Okay, and then the decision is still a human-to-human decision. And it's just really hard for machine learning to make the jump to make that decision. That's not even necessarily a feasible task. So that's one solution there that I think is pretty viable, is restraining what ML is expected to do. Another thing is we found that it's a problem with our machine learning setup that we have a data, we have a target variable, and we have inputs. Like in lung ultrasound, we found that you can look at ultrasound and find features related to pneumonia, but those in themselves are not sufficient for a diagnosis. And what the physician is doing is taking in all this other clinical data from the intake and these other circumstances, and those are necessary to do the diagnosis. So the ML model focused on lung ultrasound images is not sufficient to even answer the question. And that's another case of where all we can do is identify features to help the clinician come to their decision based on all this other stuff that we didn't get to account for.
Yeah, I guess if anyone else has nothing to say, we can end on that. ML should hopefully make healthcare more human and assist more interaction. Unfortunately, we don't have more time for any more questions, but our panelists will be around during the poster session and coffee breaks, lunch session, and we hope you can find time to interact. So thanks so much for your wonderful questions. Thanks for your wonderful answers and for being here with us.
It's my pleasure to introduce the final set of talks before we head towards posters. So and as a reminder, if you are a poster presenter in the first session, please make sure your poster is set up. So it's also a good time to go and do that. And then right after the poster session, please take it right down. So without further ado, let's start with our lightning talks. So you can come up. I'll put a timer.
Hello everyone, my name is Ali Behruz, and our work is about learning temporal high order patterns, and we aim to use those patterns to detect abnormal brain activity. Recent studies shows that there are high order dependencies between the activity of different brain regions, and this is important to understand the brain activity. And another motivation for our work is that usually most of the existing work assume that we have a predefined brain network structure from the time series data. We usually use Pierson correlation to measure the correlation between the activity of different brain regions. And here we argue that we can learn the structure of the brain network in an end-to-end manner. So basically here we propose a Hadid, which first we encode the time series data, multivariate time series data. Then we use a self-attention mechanism to construct the higher hypergraph. And then we propose a tetra-stage message passing mechanism to learn the structure of the hypergraph. Finally, we have 3 case studies on ADHD, autism spectrum disorder, and also Parkinson's disease, and show that our method can detect meaningful abnormal activity. And also, finally, we have another evaluation which we compare the Hadid with existing baselines on 3 different tasks of anomaly detection tasks, and on 5 datasets, and show that it can outperform the existing methods.
Hello everyone, my name is Pekka Markkinen and I come from Aalto University in Finland. I will present our work, transformers, self-supervised forecasting in electronic health records with attention-free models. The problem that we are considering is that we want to predict the healthcare utilization in the next year, characterized as the number of visits to the doctor or number of certain diagnoses. The dataset that we have consists of all citizens in Finland over 65, so that's roughly 1.5 million individuals in total, and the goal is to predict the overall healthcare usage in the next year. Also, we want to improve predictions in particular for divergent subgroups, or certain patient subgroups which maybe have some diagnosis like some mental health disorder or something else which makes them different from the rest of the population. And the data that we have is time series of diagnosis and treatments and medications. We spent quite a bit of time trying different machine learning models for this problem, including LSTMs and transformers and tree-based methods, as well as some even simple parametric models. And what we found out that transformers, at least in our experiments, we weren't quite as competitive as we would have hoped them to be. And that motivated us to explore some alternative models which might be a little bit simpler but still have the good characteristics of the transformers. And that's why we borrowed some ideas from the recent computer vision literature. Especially, we replaced the self-attention layers with certain NLP mixers. I can explain them on the poster. The idea is that we have fewer projection operations there, so it means that they have fewer parameters and are a little bit simpler than the standard transformer. And we also borrowed the axial decomposition idea from the computer vision literature. As a whole, the results got a little bit better in terms of accuracy as well as sample efficiency. And we also showed that this new generative summary pre-training approach that we introduced improved predictions in small diversification subgroups. Thanks. It's poster number 17 now in the first session.
Hello everyone, my name is Julian Park. I'm from ML4H School of Medicine, and today I'll present our work on multimodal transformer, which can effectively detect breast cancer and predict long-term risk using multimodal and longitudinal patient data. So, breast cancer is the top cause of cancer-related deaths among women worldwide. And one challenge we face is that mammography, the standard screening tool, aren't always effective, especially on dense breasts. Ultrasound can help identify additional cancer, but there's a downside. It can increase unnecessary imaging and biopsies for some patients. So to tackle this, we built a model to help identify additional cancer and predict future risk. What sets our model apart is that our model utilizes prior exams as well as multiple modalities, 2D and 3D mammography, as well as ultrasound. Our model is trained to predict the likelihood of breast cancer for not just right now, but up to 5 years into the future. So this is the architecture of our model, multimodal transformer, or MMT. First, MMT applies detector models to retrieve key features from each input image. After projecting these features into a shared space, MMT encodes relevant information such as study date, laterality, view angle, and patient age. Finally, a transformer encoder aggregates all these features to make a prediction. MMT is trained on a large data set of over 1 million exams from NYU Legal Health. MMT outperforms other methods that are only using one modality at a time or a simple average of multiple modalities. In short, we show that integrating multimodal and longitudinal patient data with neural networks improves risk modeling. Thank you.
Good morning, everyone. My name is Zitnik, and today I would like to give you a preview of our exciting work on deep multimodal fusion for surgical feedback classification. Now, this is a work done together between Caltech and Cedars-Sinai. It involves both AI experts and clinical practitioners. And what I mean by surgical feedback here, I mean informal verbal feedback delivered by a surgeon in the course of actual live surgery, in this case, robot-assisted surgery. Now, such feedback is important for adjusting trainee immediate behavior, but also for long-term skill acquisition and generally understanding the communication operating room. Now, actually, we don't really know what constitutes optimal feedback in this scenario, and being able to understand it requires analysis of live feedback at scale to work towards the goal. So what we do here is essentially we leverage the recent clinically validated categorization of feedback into anatomic, procedural, technical, trace, and visual aid. And this has been shown to actually predict behavioral adjustments and different skill levels of trainees. And with this, we combine information from multiple modalities. This feedback is delivered in the context of visual information, also audio and text. So we are looking at different architectures combining these modalities effectively. And we show that we can achieve this with relatively high IUCs from 72 to 78 with automated transcription. We can even achieve higher IUCs. We can rely on expert transcriber feedback. We also show that it's important to not only consider modern architecture, but also the training process in order to achieve good combination of modalities. And we achieve a gains of between 3 to even 7% on top of any single modality. So please see our poster. It's poster 26 in the first session. Thank you so much.
Hi everyone, my name is Xu Qiao, and our paper is about using the reinforcement learning for the optimization of non-pharmaceutical interventions. So the non-pharmaceutical interventions plays a very crucial action taken to control the infectious disease like social distancing and quarantine. These interventions can be costly and very hard to implement effectively. So how can we optimize the NPI's KEYNOTE disease model? There are some challenges that include the multiple objectives and limited information and the need for the simple policy. So our paper proposed a multi-objective cluster-level optimization on a simple agent-based models, and we formulate these problems as a partially observed Markov decision process, and we serve with the reinforcement learning with a supervised learning encoder. The role of the supervising encoder is to produce the estimate for the probability of infections of each close contact. And we show that it plays a very important role to in class of policies that is optimal, and which is very difficult for the ML policy to learn. So we also evaluate our proposed method on different objectives and show that it performs 27% better than a baseline from the COVID-19 pandemic. And other proposed methods, including pure RL, we proposed. However, our policy is very complex, and through a simple decision tree distillation, we show that our policy can be distilled to a decision tree on a single sheet of the paper. Our poster is at the session 1 and location 1. If you have more questions, please ask. Thank you.
Hi everyone, I'm Nsoesie, and I'm presenting our work on the importance of stepwise embeddings for heterogeneous clinical team series. So the motivation for our work is that deep learning still really lags behind tree-based methods on predicting clinical time series tasks. And so what we do is study the impact of embedding architectures, which in the tabular deep learning literature has been shown to be super important for dealing with features that are very heterogeneous. So what we do is study kind of systematically the different ways in which we can map input features XT to a type step embedding in HT that is then used as input to downstream sequence models such as transformer or maybe the transformer that we've seen before. And the different axes that we study are, for instance, if we consider features and group them into different semantic contexts, which groups of features do we consider and how does this impact performance? Then how do we map these features to the embedding space, so what sort of architecture do we use to encode this? And finally, if we choose to group these features in this way, how do we aggregate them together into a single type-step embedding that is then used downstream? And the key takeaways that we have is that indeed stepwise embeddings and optimizing this aspect of the pipeline gives us gains that are as big as optimizing the sequence model, so going from an LSTM to transformer, for instance. And in addition, we find that the attention-based methods work best, and they also give us a bit of insight, interpretability into the importance of different features. So that's a plus. Finally, like I said, grouping features into different concepts helps performance further. And this allows us to set a new state of the art on IC creation tasks and kind of bridging the gap based on some tasks
Hi everyone, my name is Alex Wang, and I'm really excited to present our recent work on learning interpretable mechanistic representations with applications in diabetes. This is joint work with my advisor, ML4H. So our problem starts where we have a time series of someone's glucose data, and we also have their self-reported meal logs as well as their demographic information. And we want to learn some kind of low-dimensional description of the ability of this person to regulate their blood sugar following a meal. Now, typically, the person's glycemic control, when it's bad enough, they are diagnosed with type 2 diabetes. In our case, we would like to be able to do this outside of the lab using data and information that's readily available from wearable information and self-reported data. Now, our setting is one that's common in healthcare, as you will see. We have unlabeled data in the sense that we don't actually know whether or not they have type 2 diabetes. We're in the small data regime in the sense that we only have a few meals per person, and we're in the real world situation with missing this. And on top of all that, we want to be able to incorporate some kind of prior information that we know about the body. So scientific knowledge that we know about the physiology and how glucose works in the body. How do we go about doing that? The way we do this is by constraining the latent space of our embedding to be the parameters of a mechanistic differential equation. This allows us to learn more interpretable representations. And in machine learning terms, essentially we take a regular autoencoder with a neural network encoder, but we replace the decoder with a mechanistic differential equation that forces the latent space to take on certain interpretable meanings. Now, as a result, we end up with much more interpretable embeddings. Here, each dot is a individual's response to a particular meal they ate. And without seeing any labels of whether they're type 2 or pre-diabetic, we see this kind of separation between all the meals eaten by a person with type 2 and pre-diabetes. So if you're interested and you work on physiological time series or any of these things that I listed here, do come to talk to me. I'm over at Poster 40. Thank you.
Thank you very much. My name is Jesse Krijten, and unfortunately not Itzhak. So Itzhak flight was delayed, but I think his research that he did was too interesting to not be presented, so let me give it a try. So what Itzhak works on is medication safety, particularly in intensive care unit. And the basic question we're trying to answer here is that you have the ICU patient and he gets a particular drug, he or she gets a particular drug. I suppose this patient develops an adverse event. Can we now say something about the probability that this drug was actually causing this adverse event? So this is a very difficult question. So we actually want to know, like, was this a necessary cause of the adverse event? And the current practice to address these issues is to basically put together a panel of experts to try to use biological and medical and clinical knowledge to come up with an answer to this question. But these answers are very qualitative. Of course, you could also imagine it's very time and resource intensive to do this, and there's a large risk of human bias. So what we try to do here is to come up with a novel approach to come up with an estimate for this probability of causation, and more particularly to get a lower bound on the probability of causation. And we do this through using a target trial emulation to try to get rid of some bias, and to use particular machine learning models, particularly T-learners, to get a sense of this probability of causation. And the good thing is that you get maybe a less resource-intensive way of getting these probabilities. There's maybe less human bias, and it's a quantitative estimate. But of course, you need the right data sources to do. So that makes it a very challenging issue. So if you want to know more about it, come talk to me, and I can put you in contact with Itzhak.
This concludes the talks for the morning session. We'll move straight to the poster session right now. We'll be going straight from the posters to lunch at 12:05. I will make another announcement so that we don't hold the poster presenters hostage. So please go enjoy the posters.
Hello everyone. First, a big thank you to the organizers for setting up this phenomenal venue that Machine Learning for Healthcare Conference has become. Really excited to be here with you today. So I will speak about this really important and an exciting problem and advances of how AI can help with rare disease diagnosis and therapeutic innovation. And this is really a joint work with the team of wonderful students that I need to call out: Michelle Lee and Emily Alcenzer, Payal Chandak, and Keshin Huang. And Emily in particular, I think she's somewhere here in the room. She's just a phenomenal postdoc who's currently on the job market. So if your department is hiring for stellar faculty, she's the one you should not miss. Okay, the focus as my group is kind of split between the initiatives that can use AI to accelerate scientific discovery and then also help with core important medical questions. I will focus this talk more around the medical domain. And so what we have done this summer is we ran a poll with Nature and asked 1,600 scientists and clinical researchers around the world on their thoughts about the growing use of generative AI in science. And so what the responses we got were that 27% of those who study AI and use AI in their research, they think that generative AI in particular will have a crucial effect on their fields of research over the next decade. And another 47% thought that it will play really an essential and important role in their field in the next decade. And so in addition to these advances in AI changing the way science is being done, in the sense of helping scientists brainstorm research ideas, helping them develop or augment scientific search engines, there is another important second pillar that the growing use of AI in medical research has, and that one is that AI can increasingly be used to augment research and provide insights that might not have been possible using traditional methods alone. And there are several examples of that, ranging from molecular sciences with AlphaFold and its various derivatives, where it's possible to predict with near atom level accuracy the structure of proteins from their primary amino acid sequence, to other models that can model biological assemblies, and even in the medical domain, develop algorithms that can provide accurate diagnosis for patients that are otherwise very hard or impossible to diagnose with traditional medicine. So there are these two important pillars about how AI is changing both the conduct of science as well as really providing new scientific and medical insights. And within that arena, my group is focusing on leveraging these latest advances in AI in order to lay the foundations that can enhance the understanding of medicine and can help with drug design, with ultimate eventual goal to enabling AI to learn and innovate on its own. And the way we are thinking of this problem at a very high level is that we are seeing this system as a complex system where we have patients coming in that need to then be matched specifically to therapeutic benefit, to therapies after they are being diagnosed. And the way to design those therapies can involve numerous different steps, including molecular design and optimization of therapeutic candidates, predicting and optimizing what are the most appropriate targets in the human body that a certain patient population would benefit from, and how to find what are those most relevant tissues, cell types, biological contexts that a specific patient will benefit from. And that is all done with the ultimate goal of accelerating and augmenting this entire pipeline of finding patients that would benefit most from a specific therapeutic intervention, and then designing and optimizing that therapeutic intervention for them. And so in the rest of my talk, I will focus on one specific kind of set of diseases that we are very interested in providing and developing fundamental AI solutions for them, because they are so currently underserved in that area. And those are rare diseases. So for those in the audience who don't know what rare diseases are, so rare diseases collectively affect 300 to 400 million individuals worldwide. There are over 7,000 rare diseases. So collectively, rare diseases are common, but individually, every rare disease has only a small number of patients diagnosed with it, and therefore it becomes really challenging to both study and investigate those rare diseases, as well as design therapeutic interventions for them. Patients experience experience often a prolonged journey to diagnosis. They can face multiple misdiagnoses that are due to just rarity or complexity, clinical heterogeneity or clinical representation of these diseases. And developing treatments is really challenging because we have poor understanding of those diseases. There are only a small number of patients that are diagnosed with those diseases. Therefore, it becomes really challenging to design robust generalizable biomarkers and interventions for them. And there is also a problem with low financial incentives for pharmaceutical development. So it's really an environment and an area that could benefit tremendously from having useful AI tools developed for those rare disease communities. And so I will give in this talk two vignettes, I will discuss two recent projects that we have worked on with the goal of helping rare disease community on two fronts. And one is that of patient diagnosis, so finding really patients that have rare diseases. And second, once you find them, how to match them to therapeutic benefit. So part one of the talk is really finding out who's the right person to go into this diagnostic therapeutic pipeline. And so why is this problem so important? This problem is so important because the diagnosing patients with rare diseases is incredibly challenging. It leads to this process known as diagnostic odyssey, where it takes on average 5 to 7 years of clinical workups, 4 to 8 medical referrals, and on average patient can be misdiagnosed 2 to 3 times before eventually they get the right diagnosis. So you can imagine this is really a big problem. If you would have now AI tools and models that would help clinicians recognize more early on that someone has rare disease and diagnose it early, that would be so much more efficient, both from the perspective of individual patient as well as healthcare as whole. Diagnostic delays are actually so pervasive that it creates real problems for patients, because patients undergo redundant testing and procedures. There might be substantial delays in obtaining disease-appropriate management, and sometimes disease can progress in irreversible manner, which means that the optimal time window for therapeutic intervention is missed. So what we have developed is a model called Shepherd that is the first approach that provides individualized diagnosis of rare genetic diseases. And it can do that by kind of introducing a new few-shot learning deep learning model that sort of overcomes several challenges associated with rare diseases. So to motivate that to work, you could say, well, this is at the core of it. It's a medical diagnosis problem. It's something that machine learning for healthcare community has studied extensively over many years in the past. And indeed, we have several tremendous examples of success. For example, in models that can diagnose diabetic retinopathy, that can diagnose common childhood diseases or skin cancers. And all of those models were generally deep learning models trained on a large number of data points, whether those were images or structured representation of medical records, typically hundreds of thousands of individual data points. So why am I mentioning that? I'm mentioning that because the challenge with rare diseases is fundamentally different than what existing models for medical diagnosis can handle. Because in the rare disease space, data sets are 3 orders of magnitude smaller on average than in other uses of AI for medical diagnosis. And so why is that the case? That is the case because we have many rare diseases and only a small number of patients for each of them. So this is not a problem that can be solved by just investing more resources to recruit more patients or label more patients and create larger data sets. It really means that a fundamental algorithmic innovation needs to be made in order to be able to design models that can leverage small amounts of patient data for each rare disease and still provide accurate diagnosis. That would not need hundreds of thousands of data points per rare disease in order to provide a good diagnostic pipeline. So that is exactly the problem that we are after in developing Shepherd model. So Shepherd is a few-shot predictor for hard-to-diagnose rare diseases. The way we can think of them is it's a model that takes as input 2 pieces of information for a specific patient. First is the set of patient phenotypes that can be coded as human phenotype ontologies and describe the clinical representation of symptoms that the patient has. And second is information on variants of the patient in their sequence genome. And those are the list of candidate genes or candidate locations on the genome that likely contain a location that is causal for location of a gene that is causal for the disease that the patient has. And once Shepherd is trained, it takes these two inputs for a patient, and what it provides us in output is that it can solve numerous important diagnostic tasks. It can prioritize and find which among those set of candidates and variants that the patient has in their genome are most likely to cause the disease that the patient has. It can find other patients in a cohort or a large system that share similar molecular and genetic features as the patient in questions. And it can help characterize novel diseases. If a patient has a disease that has never been seen before because it might be so rare, or if the patient has a disease with atypical clinical representations. There are three important key features of Shepherd. So first, Shepherd is really trained on simulated patients. So that's important to note. When training Shepherd model, we don't use even a single real-world case of patient. There are interesting consequences of that because it means that we can easily share our model across institutions. Second important feature of Shepherd is that the way we represent patients based on specifically their phenotypic and genetic information is that we think of patients as some form of activation maps or subgraphs specifically of underlying large medical knowledge graph that captures current knowledge of variants and phenotypes that the patient has from the standpoint of medical community. And that does allow us to really easily integrate prior medical knowledge into the model. And the third important component of Shepherd is that it can perform label-efficient model training because there are only a small number on the order of dozens or a handful of patients labeled per rare disease. And there's so many rare diseases, this process of training the model in a very label-efficient manner is incredibly important, and that's what Shepherd can do. Fundamentally, you can think of Shepherd as an approach that has two important steps. So step one is patient-agnostic, self-supervised pre-training. So the goal here is really to take a large medical knowledge graph that is a heterogeneous network of biomedical concepts and how they relate to each other based on decades of medical research, and learn a latent embedding space that can capture known relationships between phenotypes, between genes, between molecular pathways, between drugs and other kinds of biomedical concepts. The second stage involves taking the pre-trained knowledge graph model from stage one and use it for patient-centric fine-tuning. So here we take the model and we reorganize and restructure the latent embedding space such that it puts closer together phenotypes and genes that are known to be related to each other and associated with each other based on prior knowledge. And the way it does that is by kind of performing this fine-tuning process on a large data set of simulated patients that are designed and generated based on knowledge bases of rare disease, gene and disease associations, and are indicative of the kind of phenotypic diversity and diversity of genetic candidates that real-world patients would have. And so once step two is complete, then the model can be ready to see and be queried with a real-world patient. So one quick comment, which is what is the medical knowledge graph that is used to train Shepherd model. So this is an augmented version of prime KG knowledge graph that we built in the group. It's particularly exciting knowledge graph because unlike many knowledge graphs that are in the field, it has incredibly broad coverage of diseases. It covers over 17,000 clinically recognized diseases, and for every disease associated molecular information about the molecular mechanism of their disease and known clinical symptomatic representation. And all that comes in the form of a single unified data representation that is that knowledge graph. It's publicly available. It also it is continually updated, so we just released the latest version of Prime KG that contains all data up to July 23. So you can just go to our website and download it from there. And once the model is trained, Shepherd can perform multifaceted rare disease diagnosis. And that's something that was important for us to be able to cover a broad range of diseases, and for every disease perform a number of diagnostic tasks that are indicative of real-world questions that rare disease diagnostic pipelines encounter. And then those three are causal gene ranking, which is a task where given a patient set of phenotypes and a list of genes that contain mutations in that patient, the goal is to prioritize genes harboring mutations with the fundamental success that to put at rank 1 the gene that actually causes the disease that the patient has. The second important capability is patients-like-me feature, which is formulated as follows. Given a patient, the task is to find other patients that might have similar genetic or phenotypic features and would be suitable for clinical work follow-up. And third, characterization of novel diseases, an important feature of the model that takes as input the patient's phenotypes and provides more interpretable name or almost recommendation for a disease or an atypical representation that might be new, or it's atypical in terms of how it's currently being understood for that patient based on their set of phenotypes. And so the way these three capabilities are practically implemented is that taking the fine-tuned latent embedding space, the model can then effectively score similarity and perform retrieval from the latent space between relevant embeddings of medical concepts and the representations of phenotypes and genes that the patient has by scoring the similarity between a set of phenotypes and phenotype embeddings and a set of candidate gene embeddings that the patient has, or between patient-to-patient embeddings, or between embeddings of patients and embeddings of diseases that potentially contain the disease that the patient might likely have. So it provides us a unified way of handling this broad range of tasks within the same model. So how do we evaluate and train the model? As I mentioned, Shepherd is trained on synthetic patients alone. It's trained on 42,000 synthetic patients using this data simulation pipeline that is described in a separate paper, and I will not go into detail today. But once the model is trained, we evaluate it on 3 external cohorts. Those are patients that were never encountered by Shepherd before. Those cohorts are cohorts with difficult to diagnose patients, so the hardest cases that traditional medicine cannot diagnose effectively. And the first cohort is the UDN cohort that has 465 rare disease patients with labeled diagnoses that span 299 diseases. And already here you can see that effectively the number of patients per labeled diagnosis is just a handful, right? So it's a really challenging problem to solve. The second is my G2 cohort, which has 146 rare disease patients that span 55 diseases. And the third one is the Cypher cohort with over 1,000 aggregate patients who have received molecular diagnosis. And so let me show you some of the results, and I will focus on results here on the UDN cohort. So these are the results of benchmarking of the first capability that the model has, causal gene ranking. So as it was described before, the task here is to prioritize a set of genes that contain mutations that the patient has, with the ultimate goal of finding what is then the predicted rank of the disease-causing genes. And so the success of the model would be if we could rank the causal gene as position 1, right? So rank 1 would be the best that the model can achieve. And so what we can see here is performance of Shepherd, and interestingly, it can prioritize at rank 1 the causal gene for over 40% of patients in the UDN cohort. And it can perform considerably well than a set of domain-specific approaches, which are clinically relevant baselines that are currently used in clinical workup, as well as various traditional machine learning approaches that one could train on this data set. Interestingly, and that's the part that we're most excited about, is can these models really help solve the hardest cases, right? So not only making relatively easy or predictions that would kind of increase our performance accuracy, but can it really help with the hardest cases? And so what we have done here is look at some of the hardest cases in UDN. So those are cases where patients are diagnosed with a disease that has not yet been characterized before, does not exist in the knowledge graph, or patients have been, it has been found that the mutation that's causing the disease is located in a gene that has never been associated with phenotypes that the patients have. So those are very difficult reasoning problems because one cannot solve them by just directly doing click prediction in the knowledge graph. And so what we are showing here is comparing Shepherd to High-5, which was the strongest clinically relevant baseline, and we can see that across these 4 different categories of hardest diagnosed cases, Shepherd can considerably improve the model. Beyond causal gene ranking, the Shepherd can find other patients in the data set that might share symptomatic clinical representations as the patient in question. So this is patients like me functionality that allow us to start with a patient card of a specific individual and then retrieve other patients that might share the same, that might have, according to the model, potentially the same disease as the patient in question. And thirdly, what is interesting and relevant specifically for rare diseases is that for patients that have novel rare disease that has not been described or extensively described in literature before, it really becomes a question of how can we even kind of elevate and identify what those diseases would be and how would one go about characterizing it. And that's a possible, that's a question that Shepherd can help with addressing by retrieving from a local neighborhood of patient embeddings embedded in the latent space, retrieving from that local neighborhood embeddings of diseases that share most features with the features that the patient has, and then provide some form of characterization of this novel disease that the patient might have for clinical experts to review. To sum up, what Shepherd creates are new opportunities to shorten diagnostic odysseys for rare disease patients. It overcomes limitations of supervised learning and some of the limitations of the models that were used before for medical diagnosis but were not particularly strong at label efficient training. The way it does so by leveraging self-supervised pre-training for knowledge graphs, by leveraging large cohorts of synthetic patients, and representing patients in a more multi-modal manner by kind of looking both at the clinical and genetic data. Interestingly, what we find is that the model can generalize to novel phenotypes, novel genes and diseases. It can perform well in patients with varying amount of clinical data. It can perform well in diagnosing patients with novel diseases or atypical representations, which creates many interesting, exciting implications for more broadly useful general purpose models, as well as for using deep learning on medical data sets with incredibly small amounts of label data. So this is the first part of the talk, and what this creates is that out of large number of patients, Shepherd and Shepherd-like models can really retrieve and find what are patients with a specific diagnosis. The second part relates to, once we have those patients, how can we match them to therapeutic benefits? Once the patient is diagnosed, what kind of therapeutic intervention should they receive so that their state would improve as much as possible? And so this goes to a very exciting and lively field of drug discovery and development that has made tremendous progress over the last few years. What I'm showing in this table is just a short list of drugs that are currently in development, showing several new compounds that are entering clinical trials. And for example, in January 23, in silico medicine announced an encouraging readout of its phase 1 safety and pharmacokinetics trial that was for a small molecule inhibitor that was fully designed by AI for idiopathic pulmonary fibrosis disease. And so it's a really a field that has grown so much and created new opportunities of how to take molecules that are currently in development or medicines that are already on the shelf in order to find and then repurpose and effectively use them for patients that have been diagnosed with diseases. And the question then becomes, how can we find, if we look at these huge shelves of drugs and on pharmacy, in pharmacies, what are the drugs that a specific patient would benefit the most for, and how we can do that for rare diseases in particular. And so this problem is called drug repurposing, that is concerned with the question of taking drugs and medicines that are in later stages of drug development or are already approved on the market and see if there's an effective way to repurpose them for new indications in new diseases. That is incredibly important for rare diseases for two reasons. First, there's no effective treatment for most of rare diseases. In fact, of over 7,000 rare diseases, only 5% have any FDA-approved drugs. So it's simply not sufficient to develop models to diagnose patients. But once patients are diagnosed, how can we match them to therapies? And second, drug repurposing is an enticing alternative to designing drugs from scratch because it can lead to faster translation to the clinic and lower development costs. So what I will just very briefly mention is a model that we have developed called TXGNN, which is a therapeutic graph neural network model that is an all-disease drug repurposing model. So it's the first model that can identify drug repurposing opportunities over a large number of diseases, 17,000, including the entire space of currently recognized rare diseases. And the way it can do so is by bringing together multi-scale and multi-model biomedical data, representing it in a unified manner to knowledge graphs, and then train a single model that once trained, it can be adapted to a broad number of diseases with no or really minimal training. And so the way with the high level, you can think of TXGNN model as a model that takes as input a primary knowledge graph, and it's then optimized to process therapeutic use prediction tasks around indications and contraindication for any pair of currently approved FDA drug and a disease that is present in the knowledge graph. And that leads to many, many exciting opportunities, of which I will just mention this one, where after extensive benchmarking of the TXGNN model, we evaluated the model in numerous different ways for specifically its novel predictions and their utility for real-world drug repurposing. And what we found is that novel predictions made by the model that do not correspond to any of the current FDA approvals are strongly consistent with off-label prescriptions that clinicians make in large healthcare system, which was a study where we compared novel prediction of the model and evaluated them in over 1.2 million medical records of a healthcare system. And the model can also predict accurately therapeutic use for recent FDA approvals after it was logged and asked to forecast future FDA approvals. And it can inform laboratory settings, producing an order of magnitude improved yield in biological experiments relative to what was possible before. Let me skip to this part where I'd like to summarize how these two models come really together and where the future is with AI for rare diseases, how we can go from these mysteries that rare diseases often are to effective diagnosis and effective therapies. And the way this is done today is through extensive and really awfully challenging for both patients and healthcare professionals and researchers diagnostic and therapeutic odysseys. And what we are seeing the future here is that of using Shepherd and TXGNN and models like these two models in order to pave the way for individualized diagnosis of rare diseases, and once diagnosis is achieved, also matching those patients to drugs that are ready to be used for them, which often is done through, which can be done through drug repurposing mechanism. And this, of course, would not be possible with tremendous support from our funders and just incredible students that I'm able to work with at Harrer. And happy to take any questions, or we can defer that later for the panel session.
We will save all the questions for during the panel. And thank you, Dr. Marinka Zitnik. And our next speaker is Dr. Marinka Agrawal. Dr. Marinka Agrawal recently earned her PhD in computer science from MIT and is an incoming assistant professor at Duke University. She's a co-founder of Layer Health, a recently launched health technology startup. And she has been the recipient of several fellowships and was named 2022 Rising Star in Geeks. Dr. Marinka Agrawal, please take it away.
Thank you so much for that kind introduction. So today I wanted to reflect on LLMs in medicine, and particularly some work I've done at MIT over the past 2 years or so. So large language models are incredibly exciting right now because language is embedded everywhere across medicine, from clinical notes to medical literature. And it really connects many different stakeholders in medicine, from clinicians to researchers to patients. But I also think that clinical text, even in things outside of traditionally considered clinical NLP, clinical text is really important across machine learning for health. So causal inference or reinforcement learning, where you're trying to optimize the best treatment for a patient, or disease progression modeling, where you're trying to model a patient's disease trajectory. To answer those questions robustly, we need to know variables like comorbidities, side effects, treatment efficacy, drug status, and a lot of those are not often found in structured data, but instead trapped in messy, complex clinical notes. They're often only structured in things like clinical trials, which is not true of most of our data. So I want to kind of quickly talk about why understanding clinical text is so messy. So here's an example of like a really short snippet that's not so different from the sorts of things you might see in a clinical note. And if we want to understand what's going on here, we first have to understand what are the clinical concepts. But we might parse this. We could start by saying that TNBC pretty much always stands for triple negative breast cancer. And given that, we know that carbo probably means the chemotherapy carboplatin and not the cream carvodome. And now that we know we're talking about this chemotherapy, IA probably means intra-arterial and not intra-articular. And now since we're talking about a drug, DC in this context is talking about the discontinuation and not something like a discharge. So for something as simple as a 7-word snippet, there's a lot of hops of reasoning that one has to do to even understand what's going on. And this is also a field where we often don't have a lot of labeled data, kind of labeling what is the meaning of the words in clinical text. So as a result, I think large language models have a real role to play in interpreting clinical text. So I'm going to start by talking about that. But then I want to kind of take a step back and talk about the clinical data that's sort of behind these large language models. And then I want to take even a further step back and talk about how is clinical data generated and how should that affect how we do large language models in medicine. So first I'm going to talk about how we can use large language models to interpret clinical text. So this was a paper at ML4H last year, joined with the co-authors you see here. And what we were interested in was whether large language models like the GPT models could help us parse clinical text. And this was done on models of, that are now 1.5 years old, but what I found is that a lot of these same trends have still continued even with the newer versions of models. So the first hurdle in doing this evaluation is avoiding label leakage. So if we were to do benchmarking with existing public labels, what might occur is that the large language model might have seen the answers in its training data. So to get around that, we annotated a publicly available data set to release 3 new data sets that are available on Hugging Face. The second hurdle is having evidence-backed output. So let's say the goal here is to list medications and their reason, dosage, and frequency as they may be available. And let's say the node contains something like 500 milligrams of metformin BID. The expected completion we might want is something like medications metformin, the dosage is blah. But what you might get in reality if you were to kind of just do this is something that's like the medication taken is metformin for the reason of diabetes and a dosage of blah. The first issue is the narrative format. But the second issue that I think is kind of well talked about is one of hallucinations. So in this case, it presumed that the reason for the metformin was diabetes. And diabetes is the most common indication for metformin, but it's not the only indication. And what we don't want in our data sets is kind of pollute with what's the most common indication, since that could skew our data sets. So, as is now methods in this area, we used a prompting strategy to kind of guide towards what we wanted by providing a one-shot example of the kind of format we wanted, shown in green, and kind of forcing it to quote. So instead of allowing it to answer with anything, being able to tie every single thing at output to a specific thing in the input, and made it much easier to verify that it was not filling in things like diabetes. And the third and probably largest hurdle is one of deployability. So models are quite sensitive to prompt wording. For anyone who sort of played around with things like ChatGPT, depending on exactly how you ask the question, you might get a very different answer. And further, these models are often miscalibrated and sometimes overconfident. So even if the probability of yes should be like 0.7, it might often skew to like 0.99. And as a result, it's hard to know when should I trust the model output, because they often can sound quite confident. And especially more recently, these large language model providers aren't necessarily making the underlying log probability use large language model outputs as weak labels. So step one is on some data sets, so here shown in purple, get your large language model outputs. So here each box represents an example, and each color is a class that the large language model classified the example as. And step two, which I'll talk about on the next slide, is identify the outputs where the model is more likely to be accurate. But importantly, we're not trusting the model's own definition of confidence. In step three, we then train a smaller model. You could think of this as something like a clinical bird-sized model on only that subset of outputs where we were confident. And now we can actually run that smaller model on either that same data set, and it can actually correct places where the original data set was incorrect, where the LLM was incorrect, or we can run on new data sets that potentially for reasons we might not want to send to an LLM provider. And there's further examples of this in my colleague Hunter Lang's Nsoesie paper from last year. So then the question is, how do we select more accurate outputs? So because deep models are wildly overconfident and miscalibrated, how can we determine when to trust their outputs? So the solution we came up with is first, embed each example X with phi of X. So in this case, phi of X is some other embedding method. So you could say, clinical bird alongside your GPT. So in this diagram, each circle is a different example, and the color is what GPT labeled it as. But now we embed it in space based on some other embedding, something bird size that you can kind of easily manipulate. And second, what we want to do is make a k-nearest neighbors graph in this phi embedding space and see which points are closest to each other in this embedding space we do have control over. And then what we want to do is find the regions that are most homogeneous. And in doing so, you can think that the higher level concept is you're trying to figure out when does, say, the clinical BERT agree that these examples are close and GPT agree that these are close. And by selecting just those subsets, what you end up with is a subset of the data that's more accurate than if you were to use the entire data set for training. And there are many examples of this in Hunter's Nsoesie paper if you would like to look at more. So just to give one result that we looked at, this was acronym disambiguation. So this is a task where your input is a snippet of clinical text and some acronym that can mean many things. So PT can be physical therapy or procurement time, and the output is a multiple choice expansion of that acronym. So in red, you can see kind of a zero-shot baseline trained on mimic data, which is a different distribution, and compared just using kind of GPT out of the box, in purple you can kind of significantly outperform in the zero-shot setting. But now in green, what you can see is what happens when you add that weak supervision step to improve even further. So now I kind of want to talk about the clinical data behind large language models. So these general purpose models, as we saw in the last section, and we've seen in a lot of headlines over the past year, these general purpose models are performing quite well in the clinical domain, despite not necessarily being trained on clinical corpora specifically. So I think it's really important to investigate, what are they actually training on? And I see this motivation as twofold. So first, for when we use general models in the community, it's really important to understand the content of what is and isn't in the training data, since this can indicate where the model may perform well or perform poorly, and also elicit what biases might be in the training data underlying these models. And second, for when we're trying to train our own custom clinical models, it can help us answer how can we augment the pre-training data that we're using to be more diverse. And to give an example of why this might be important, a lot of the applications people are interested in nowadays are more patient-facing. And if you were to think about building a translation model from, say, Spanish to English, you would never train only on Spanish data. So as we're trying to come up with models that can answer clinical questions in more patient-facing language, we should be looking at potential data sources outside of clinical text and clinical notes alone. So to provide some motivation, here's a chart from a recent review from earlier this year, kind of cataloging all of the different kind of clinical large language models. And what you can note is that a lot of them are trained because of limitations of sharing of clinical data on a single institution's data. So I think Mimic is very common, or a single site of EHR, potentially, augmented by PubMed. But I really remember 2019, I was at the AMIA Medical Informatics Conference in a room full of doctors who were all talking about how NLP did not work and how computer scientists did not know what they were doing. I was like kind of hiding, hoping no one could tell who I was. But kind of the crux of their issue was that they often had a model that was kind of promised to them that had been trained somewhere else, an NLP model, and then they tried to use it on their own data, and they'd been promised, X% accuracy, and they found that it fell really flat. So I think there's a lot of questions about how can we build things that generalize well, given that we often aren't sharing across sites in training data. But despite this, these general purpose models are doing quite well, despite not being trained on single sites. And the second motivation is the fact that there's a lot of long tail knowledge in medicine. So this is a paper from ICML this year that described that a language model's ability to answer a fact-based question is correlated with how many times the answer to that question was seen during pre-training. And then what you see here is that there's huge bumps when you get to like hundreds of thousands of examples, and often in a single site EHR, you're not going to get data like that. So it really begs the question, how can we kind of augment that training data? So I do not have access to OpenAI's training data, but 60% of the GPT-3 training data was a filtered set of the common crawl, which is a crawl across the internet. So as a proxy, what we investigated was C4, which is this colossal clean crawled corpus from Google that the T5 language model was trained on. And this is not quite as large as the GPT training data, but I think it can serve as a proxy to sort of understand what sort of clinically relevant data sources exist in the common crawl. And as a note, this is not actually published work, but I think it's in like chapter 7 of my thesis. So if you're interested, you can look there. So what we wanted to do is we used the Allen Institute has a utility where you can actually search easily the C4 data set. So what I wanted to analyze was for technical jargon, so things like prothrombin time is often shown as PT, or more colloquial jargon, where doctors might write fractures, FX in a note, try to understand where are the sources that this data appears, and also the frequency of those appearances. So digging into the kind of pre-training data, so for, and this was done for, I think, like 100 acronyms. So for the colloquial jargon, that subset, what we find is that there's actually a very solid scale going from research articles, so I think PubMed, which we often pre-train on, which is at about 16%, but it's far from a huge majority. So we see things from patient health resources to commercial health sources to clinician and patient forums. And what's particularly interesting is that's not uniform across the different things. So for something like Carbo and Carboplatin, 40% of those mentions were in patient blogs and forums. And for mentions of AMA as advanced maternal age, that's also concentrated in patient blogs and forums. So what that indicates is that we might want to have, if we want to have good coverage across concepts, we need to look at a diverse set of sources. And if we look at occurrences of jargon, things like PT or physical therapy happen quite regularly, whereas NAP or nothing abnormal detected only appeared 14 times in that data set. And PR per rectum was actually filtered out everywhere for content filtering, so you actually might not do well on things you might expect, like genitourinary diseases. And Dodge et al. At UNLP 2021 actually found in their analysis of C4 that medical information was commonly excluded. So this is a call to kind of really try to understand the data that you might be training on and what its advantages and disadvantages might be. So finally, I want to talk about generation of clinical data. So clinical documentation has long been a challenge. You can ask any doctor that you talk to. This is a snippet from an ACL paper from 1975 on the linguistic characteristics of medical notes. And they're called a compressed type of linguistic material, and the entries have to be brief to save time and effort. And as a result of this, it's very natural that LLMs are now being explored for generation of clinical text. But as we start to do this, I think to really aid in that we really need to take a step back as computer scientists and understand the status quo. I think this really dovetails on what the panel was talking about this morning, of how can we understand the existing process before we try to add machine learning to it, if that's the right solution. So I think clinical shadowing is often one way that I find really valuable, but another approach I want to kind of quickly advocate for are audit logs. So audit logs are useful biocodical electronic health records that were originally intended for access control. So in the electronic health record, it captures things like clicks, page views, note saves, and it's long been used by the medical informatics community to kind of understand what's happening. And what I'm kind of arguing for is that they can be used for two purposes. One is to kind of better understand and characterize at scale the existing processes within EHRs, but also monitor changes in clinician behavior when we try to intervene with solutions. So as an example, this was work led by my master's student Sharon Chang, published this year at ML4H, where we were trying to look at audit logs specifically in the emergency department setting. So on the left, what you see is a patient note, and it's actually not written all in one monolith, but actually over several periods of time. And you can see that kind of indicated by colors, but it's not that the writing happened alone by a single person, and what you see on the right are the other sources that they could have referenced while writing that note. So using those audit logs, we can tell if they actually looked at, in this for example, 5 different notes across 3 different doctors. So instead of saying that the way the note was written was beginning to end all at once, the note generation process is actually much more complicated. And on average, in this data set, and there's more statistics in the paper, these ED visits have like 7 writing sessions, and they had like 8 notes that they looked at. And so as we move towards incorporating AI to speed up clinical workflows, it's important for us to be minimizing unintended consequences, since there's a large literature on how automation bias occurs in medicine. So in pilot evaluations, audit logs can help us monitor effect sizes at scale without the human bias. So in user studies, people often don't notice that they're susceptible to automation bias, and having sort of this data can help us understand what's really happening. So for example, we can understand how workflows are changing for better or for worse by example seeing, are they still looking at as many references as they would have beforehand? Or if we're doing retrieval augmentation, are those sources being retrieved? So in final takeaways, large language models indisputably hold great potential for medicine, but naive application can be sufficient. They should be seen as a means to an end rather than an end in themselves. We should, as a community, better understand the clinical pre-training text underpinning these general LLMs. And finally, we really, as a community, need to think critically about how clinical documentation is generated so that we can kind of effectively be good clinical partners. And that's the job.
Thank you, Dr. Agrawal. Next up, we have Dr. Stefan Harrer, who is the director of the AI for Science program at CSIRO, which you can see from his t-shirt. And CSIRO is Australia's national science agency, where he leads a global innovation, research, and commercialization program aiming to accelerate scientific discovery through the use of AI. Dr. Harrer holds 71 granted patents, and he's a member of the New York Academy of Sciences, the IBM Academy of Technology, and a senior member of the IEEE. We're super excited to have Dr. Stefan Harrer with us today. The stage is yours.
Thanks a lot. Thanks for the better introduction. Thanks everyone for having me. We tend to massively underestimate the pace of technological progress. We almost always get it wrong. That's because we look back, see what we've seen in our lifetime, and then we extrapolate linearly. That's not what happens in reality. Things go much faster. They're actually on a hockey stick curve. And generative AI is on a hockey stick curve on steroids. Now, it's not just the pace of technological progress, but really also how experimentation happy we are. right? How well we are equipped and how quickly we jump to exploration when we see something that we like and we think, this is truly got potential to change our lives, make them easier. If you look at the fridge, it took a little to get it into households, the telephone landline, much quicker, and microwave, even quicker than that. Computers, smartphones, super fast, and ChatGPT's got to be like the top score on this, right? From 0 to 100 million daily active users in 2 months. This is pretty daunting. What you do in this situation is you can pretty much only do one thing, right? So if you have a technology with that kind of momentum, there's no way holding it in its tracks. So all these calls for bans and that sort of stuff, it's, they all have good intentions, well, supposedly, but they're not going to be realistically changing anything. What you can do, and what everyone should do, is take their part, their role in responsibly developing and exploring this technology so that what it's being used for in the future actually adds value and does this in a safe and responsible way. This is pretty much the situation that also I found myself in pretty much the day of the year ago when ChatGPT was released. Pretty much all of a sudden our fund was inundated with proposals on how to use ChatGPT and large language models for all sorts of applications. This happened, of course, in the pretty much complete absence of any noteworthy regulation around using generative AI in health care and life sciences and medicine. At the same time, though, it was exactly as I just described it. It was very clear that something had to be done, that you needed to find a way to safely explore and put these endeavors on a hopefully successful path so that they would lead to meaningful systems and solutions in the future. So, one of these applications that came to us all the time, and this is also one of the landmark studies, I think, of this year, is the following one. The experiment goes like this. There's an online repository of clinician-patient interactions. Patients ask questions online, GPs answer. These were documented, and then they were actually given to human subject matter experts, clinicians who rated the answers that clinicians had given with regards to 2 dimensions. The information content, the quality of the content that clinicians were actually providing, and second dimension, the empathy with which they formulated these responses provided by the patients. Then second step of the experiment was, you assume you might have written this study already, is to give these questions to ChatGPT, let it do the same thing, do its magic, and then have the same folks rate the answers that ChatGPT gave with regards to the same dimensions, empathy, information content. The outcome was mind-boggling, because not only was ChatGPT rated as more informative and more competent in its answers, but also the empathy score of the answers that it gave was significantly better than that of human GPs. Now, based on this, people immediately thought, oh wow, right, so we can now use this technology and we can immediately think of all sorts of supposedly interesting applications that substitute or enhance the burden that sits on clinicians when they actually interact with patients in all sorts of ways by using this. Now, not so quick, right? There's a lot of things that can go wrong, and there's a lot of things that have to be understood and controlled before you can use a technology like this as part of a system that you roll out. This is something that, as I just said, is of course a regulatory question in many ways. The problem, though, is regulation is far behind, right? The rate with which evidence is created that would support any sort of regulatory standards is not at all anywhere close to the rate with which the technology stuff progresses. How do you navigate this regulation gap? Like, how do you go through the sausage-making phase without being completely off track or setting yourself up for failure? Now, fortunately, there are principles, and they're not new, right? These are the bedrocks of AI ethics, ethical design, use, and deployment of AI technology. Right? You see them on here. There is accountability. Someone needs to be on the hook for releasing something into the wild, right? Next one up is value alignment. What your AI system does when you release it should be aligned with the purpose that you had in mind when you designed it in the first place. If that's off, you have the famous alignment problem. Then explainability is something that's particularly important in healthcare and life sciences, where patients' well-being and health is on the line, right? Making decisions in that kind of atmosphere makes it very important and desirable to understand why an AI system might have provided a certain recommendation to you as a clinician or as a patient, why you should follow this clinician's advice when they have actually sourced it partly from an input from an AI system. Then we have fairness, which we've heard a lot about already today. And then there's data privacy issue, which means because data is there doesn't necessarily mean you are allowed to use it. We get to that later. Now, the World Health Organization, we've seen another very good framework of them just earlier today, has also produced a very famous document here, the guideline on ethics and governance of AI in health. That is a general projection of these ethical principles on AI in health, but it is, notably because it's written in 2021, very short-lived, or actually doesn't have much in it with regards to generative AI. I developed essentially for a fund a due diligence framework that looks into assessing risks and identifying risks. We're using generative AI based on this WHO framework, WHO framework, and that's published. That came out a little earlier this year. The reference is on there for you. Now, that alone in itself is not a self-fulfilling prophecy, right? There's a lot of ethics frameworks hanging around, and that often is something sky high, very esoteric. You gotta drill it down into reality and find ways to actually apply it. So this is what's the follow-up publication here. That's much more already, as you can see by the title, born out of a vivid discussion that actually originated from publishing the paper in the first place, here with colleagues from the pharma sector, that talks now about how do you take this ethics framework and how do you apply it really where the rubber hits the road and assess the risks, the opportunities that lie in a pitch, in an idea for building a system in healthcare and life sciences based on generative AI. There's a few principles that I don't bore you with. All the ethics framework is very comprehensive and has pretty much everything in it that needs to be looked at. It can be boiled down to a few general steps, which is how we would approach it, how we would also see regulation develop around this in the future. The first principle is really to regulate the outcomes of AI, not the technology itself, right? Look at the use case that this AI technology is being deployed into. And that's what you need to worry about, not the name on the label of what kind of AI technology type is being used. And once you've got that, assess the risks, right? It's not, it's really not a one-fits-all approach to have a risk and you then just use that risk as something in a thumbs up, thumbs down kind of thing. You need to weigh risks against each other. There's got to be a risk-benefit assessment for using AI, generative AI in a use case. Then, build policies, adapt policies, understand what can go wrong, what you're trying to avoid, what must not under any circumstances happen, what you're willing to take as a risk, and write this down and make this an accountable, auditable document. And then start cautiously experimenting and applying it and putting it into motion. There's nothing worse than paralysis by analysis. There's something you gotta do about it, and we'll get to that in a second, how that goes. So these are really the steps on how to approach this. Now, in order to do that, there's a very good think tank out there, the Coalition for Health AI, which I pleasure working very closely with around these matters. The mission essentially, and the vision of this think tank is to do exactly that, to provide guidance on how to navigate the implementation of AI in health and medicine use cases. Now, these are the folks in this. The important thing here is that it's super important to have all stakeholders of this value chain in this process, right? Clinicians, developers, providers of technology, industry partners, regulators, everyone's gonna play a part in this. And it's very important that communication is vivid and both ways with all of these stakeholders. That Coalition for Health AI has published, called a how-to guide, right? A very comprehensive framework, a pragmatic implementation framework on how to apply and develop responsible AI solutions in healthcare. And this is a document that you can look up, and I find a very good guide to go by. Now let's go back to our initial application, the chatbot, the empathetic chatbot. How would that look like if you now went about assessing this opportunity if it came to you as part of a pitch? Now, firstly, think about the use case. You can't read this. It's a comic that came out just last week, I think, or a couple of weeks ago, in the Los Angeles Times by a very cool clinician from Johns Hopkins University who actually wrote this comic about, it's an op comic, who wrote this about exactly this JAMA study that I talked about. And what we can learn from this comic is really to define the use case. The use case in which you would, how you would use this GPT technology for a specific solution. So in this case, it's pitched to be a coach for a clinician, to help be more empathetic, find the right tone in certain interactions, be the infamous co-pilot sitting on the side. So this is important, right? Because it defines already the role of the human in the loop. It's not an accountability sponge, right? It's something that sits aside from the technical solution and works together with the technical solution, but actually has accountability for using it. So after we know that, we can now look into what could possibly go on with the main risks are. This is where you want to have the neuroscientists, the psychologists, and the technologists in the room. There's three main components to empathy. The first one is cognitive empathy. You can put yourself into other people's shoes, understand why they are in a different state of mind. The second one is what's called emotional empathy. You can put yourself into other people's shoes and you start feeling, like you develop emotions from that. And the third one is compassionate empathy. You now also feel the urge to do something about it, right? So these are the aspects of empathy. And now let's look at artificial empathy and how that could play out. First one is theory of mind. There's a very interesting study out there that essentially exposed ChatGPT to a standardized cognitive test that the Delahunt test that actually tests patients on the autism spectrum. And I won't go through it, but it's essentially a very simple scenario, and depending on the very simple answers that the patient gives, a diagnosis can be made. That scenario was actually put to ChatGPT, and ChatGPT passed with flying colors. So lately, there has been some discussion around the methodology behind these initial studies, and that's something to follow. But the point is that there's all sorts of indications here that ChatGPT developed something akin to theory of mind. Does it feel? No, it does not, right? So this was a controversial case last year. You might remember the Google engineer got fired for publicly stating the belief that the LLM had been conscious. And subsequently, there were studies that applied the methodologies of assessing, understanding consciousness to large language models, self-awareness, and the conclusions from this paper were very much that there's nothing that indicates they develop emotions. But also interestingly, right, and quite controversially, nothing that would outright prevent that from happening sometimes in the future. The second one, third one, the compassionate empathy one, is what I find the most interesting one. And this is a paper out here that appeared just earlier this year. Insights as follows. Language models beyond a certain size very clearly and abruptly develop socioeconomic norms such as bullying, inappropriate behavior in how they actually interact with humans. Now, while that is concerning and immediately led to all sorts of discussions around that must not happen, and this is something that we need to tackle shutting them down. People looked into it and discovered a way to counteract that very efficiently. And that is to tell these models essentially in layman's terms, don't do it, right? Don't like literally prompt the model and ask it to actually self-correct their moral missteps. And that works to some extent, right? So now we've found a way of how you could assess and mitigate a risk through knowing technology that runs under the hood. That leads us to the last step in this due diligence process, which is like, think about the outcomes. So you apply this, think about the outcomes. Playing devil's advocate in favor of this use case could be something like saying something like, well, yeah, this is the AI. Humans will never really, take it serious or, be affected by it. Similarly to when a human interaction takes place, but this is not true, right? A hug, be it like given to you by someone who you love, versus a hug by someone who just observes etiquette. They are different hugs, right? But the result, the impact, the feelings that it stirs, they can be very similar. So even though it might be AI that behaves inappropriately, it might still have effects that are similarly impactful, like when a human would do this. So we need to really understand that these implications are something that need to be accounted for when we develop and apply and integrate ChatGPT or large language model-driven chatbots in patient-clinician interactions. Back to the Coalition for Health AI process. So we developed essentially a process that will go through these steps. There's a lot of detail in this, which I'm not going to go through, but again, look to that document, guideline that I referenced in the first place. The essential point being of this work is not a one and only occasion that we need to do this audit. There's got to be constant monitoring, refining, assessing the technology in the operational environment. So the takeaway from this chart really is that you're looking at a cycle that needs to be applied over and over again. And it's important to have this going on if you want to continuously develop your AI technology as part of a real-world solution that adds value and that has a fighting chance of picking up problematic behavior or risks on the go. Now, this is something that is actually being done. So we work with a few of clinical partners on actually going through these processes. There's a couple really, also really cool self-reported case studies that have come out lately. This is one of them. We ran one down in Australia as well. And this one just came out very recently, where the findings from running these experiments, these sandbox studies, are actually shared publicly. And that's another very important thing, right? We can all learn from each other from doing these early stage experiments, these explorations, right? That's really very crucial for everyone in that ecosystem to share the findings and make these public. And some might be surprising, others might be really extremely beneficial, but it's really important to talk about these things and share this. Now, what to look out for, right? I talked about regulation and how it's important to understand, or at least have a grasp on where regulation goes. And that in itself determines a lot of the success chances of coming up with a new idea for a new startup or a new solution or some system that uses generative AI that you want to deploy into the real world. I want to highlight two aspects, right? Two sectors that everyone should have really very, very closely on their radar. The first one is the copyright in medical terms. It quickly becomes a consent issue. So here's the conundrum. There's a couple high-profile lawsuits going on. They're all ongoing. Nothing is really being solved there, and they will be extremely decisive on everything from copyright to accountability in the use of generative AI in healthcare, but also beyond. The problem goes like this. It started in the world of the creative arts. Artists were actually complaining that providers of large language models had just scraped their data of public sources, then ran it through their generative AI machine, and at the end produced something that they took credit for without reimbursing the owners of the data in the first place. And the response of the providers to this was, well, look, that's what art is. We've just taken this stuff and we've created something new. This is what generative AI does. So you're sorry, but this is really something that we have created with our technology, and you shouldn't have really a part of it. This worked out until the first instance of inappropriate content was created, and people started really complaining and screaming like a murder that something like this was actually possible and done with generative AI. At that point, the line of argumentation changed quickly to the developers saying, well, yeah, okay, Section 230, Free Internet Act, so what that is essentially is if I post inappropriate content on my website, I'm responsible for it, and not the provider of the server. So developers claimed now, well, they were just using the initial content, and it was still that nature of the initial content that came out of the other end of the generative AI model. So really nothing new to it, and the responsibility for whatever came out of this at the other end would still lie with the originators and not with the developers of the model. Of course, that was the gotcha moment for those who actually had complained in the first place, because you can't have it both ways, right? Either you're responsible for what comes out of it at the other end, or you're not, and then you pay. And this is really what goes on right now. Right? Watch these cases, right? We have them in the music industry. We have them in the creative graphics industry. There's a lot of those going on right now, and very high profile at that, and they're not separate. So that will determine really the corporate data ownership and accountability issues in that. And the last and the second part is the EU AI. It couldn't be better timing. Just on Friday, it was actually the terms of the AI were finally ratified and accepted. This is the first piece of binding contractual legal framework to govern the use of AI, and including explicitly so generative AI. And there's a lot that is in that act, but the things I want to just highlight as the most important ones, the aspects that it actually puts its finger down on, is transparency, right, around training data sources and training mechanisms for generative AI methods. Then the need to report and label AI-generated content as such. And that's a good thing, I think, a very strong tendency to go to precision regulation, which is the kind of regulation that doesn't outright regulate individual types of AI, but actually the application of use cases. And the US is pretty much, much in the same kind of field there. When you looked at the Senate hearing of the Judiciary Commentary on Committee on AI just earlier this year, you could hear very loud voices on precision regulation as well. And also the executive order that the Biden administration put out recently goes into that direction. So, in summary, in that book that I just published together with many very brilliant colleagues, and also through these places, email or LinkedIn, find me, ask me any questions that you might have, commentary. It would be very interesting to hear from you if you have any experiences in actually really trying to get generative AI-driven pitches and ideas into real-world applications and use cases. I think it's a very, very interesting area to be in. It's one of the quickest growing markets, but also one of the most hard to read and hard to predict markets. So you'll see a lot of hesitancy to invest in it, but you also see a lot of enthusiasm to invest in it. So that's an exciting place to be in. It needs to be navigated with caution and knowledge, and I'd love to help you with that. Thanks a lot for your attention, and looking forward to any questions you may have.
Thank you, Dr. Stefan here. Our last speaker is Dr. Tao Tu, who is a senior software engineer and researcher at Google Research. He obtained his PhD from Columbia University in biomedical engineering, and his recent work investigates the use of large language models for various biomedical and clinical use cases, which you all hear about.
Thank you so much for the organizers, and I'm very excited to be here to speak on behalf of our research team at Google about some recent progress that we had on the applications of large language models in biomedicine. So with models like GPT-4, and Generative, we have outstanding general purpose intelligent systems. They are very knowledgeable in a broad range of topics, and they are very much like a very smart friend of yours. So they can talk to you about philosophy, science, literature, and whatnot. But when you have a medical concern and need advice, would you go to this friend? No, you can go to a doctor who has undergone rigorous training and is licensed to practice. And similarly, we need AI models that are specialized for the medical domain. And this is what we have been doing and building at Google, sending AI models to medical school, aligning them with the values and the practice of medicine. Over the last year, we have had a series of research papers which tell us what capabilities of these new large language model-based AI systems have and what the future might look like with AI at its core. With our ML4H work, we showed that by aligning and specializing these models to medical domain, we can reach expert level performance in medical question answering benchmark, for example, the US medical license exam, and also in the side-by-side blinded comparison, ML4H answers were preferred over physician-generated answers by a panel of independent physicians on 8 of the 9 axes related to the factuality and reasoning. So what made ML4H so useful are 3 things. The first is a very strong language model backbone. The second is very effective end-to-end fine-tuning algorithm leveraging expert knowledge. And lastly, a better reasoning strategy using ensemble refinement. So the high-level idea is we are feeding the model its own reasoning paths and ask it to condition on its own reasoning paths to refine its final answer. Since medicine is inherently multimodal, so we added multimodal capabilities to ML4H and make it a true journalist biomedical AI. This model is capable of not only understanding clinical text, but also interpreting medical images, grounding its response in the context of HR, writing radiology reports competently, and also interpreting genomic data. ML4H multimodal, short for ML4H is our first demonstration of a journalist biomedical AI system that can encode and interpret modalities spanning text, image, EHR, genomics with a single agent, and can perform multiple clinical tasks at the state of the art. ML4H is built on POM-E. This is a generalist vision language foundation model that is designed for robotics. POM-E has a very flexible architecture. It has a multimodal encoder, an alignment layer, and a language decoder. Multimodal data first are encoded into tokens and then projected into the same representation space as the text tokens. This enables interleaving of, for example, image tokens with the text token to form multimodal sentences. And the encoder alignment layer and the language model can be fine-tuned end-to-end or together or individually. We created MedBench, which is an open source biomedical benchmark that we use for the development and evaluation of ML4H. And this benchmark contains 14 biomedical tasks spanning 7 different modalities. Tasks include medical visual question answering, image classification, genomic variant calling, and also radiology report generation and summarization. with over 1 million examples. Modalities span dermatology, pathology, radiology, and also genomics. So we fine-tune the model to perform all different types of tasks at the same time. And this is done through task-specific instruction fine-tuning. In this radiology report generation example, we asked expert radiologists to craft very detailed instructions on how to write a report. And then we also provided the model with context information like the reason for the study, and asked the model to condition on the chest X-ray image to generate findings generate the report that describes the findings in the X-ray. And similarly for the dermatology classification task, we provided the model with the patient clinical information alongside with the skin lesion image and formed the classification task as a multiple choice question. Because we are using a unified framework, and also we can flexibly interweave multimodal tokens with the image tokens. So we can do all these different types of tasks with the same set of model parameters and jointly train them. ML4H achieved near or exceeding specialist pseudo performance with a single set of model parameters and a unified model architecture across all the tasks and modalities in the multi-net bench. And here the comparison is against single specialist models that are optimized for each of the tasks. So we know scaling is very important in language domain. We also explored the effect of scaling in the multimodal domain. So what we observed is for generative tasks such as the radiology report generation, scaling the language component is very helpful. But for classification type of tasks, I think the bottleneck is still at the image encoder part. So one exciting emergent capability that benefit from jointly training all the tasks at the same time is the generalization to new task. So here, despite there's no tuberculosis pathology label in the training set, the model was able to zero-shot generate report describing a chest X-ray with TB findings from a completely new data set. We also performed radiology evaluation on the machine-generated report to evaluate the quality. And what we found is, on average, ML4H had 0.25 clinically significant error per report, on par with the human radiologists from the prior studies. So I think while our work received a lot of attention, we at Google believe in not just bold but also responsible innovation. So we have been working with many large healthcare organizations and academic partners, trying to understand the use case of these models, but also, more importantly, the limitation and the failure mode, and trying to use the feedback to improve. So we are happy with the progress we have made, and ML4H will be open to general access in the next month or so. In parallel, we have also been working on closing the loop and paving the road for real-world impact with this biomedical AI system. In a recent preprint, we developed a new language model optimized for diagnostic reasoning, as well as a UX tool for clinicians to interact with it. We did a randomized study across 300 New England Journal of Medicine case challenges with a group of 20 experienced or certified internists. The internists were randomized to either using search or using language model as assistance when trying to come up with the top 10 differential diagnosis for each case. Well, what we observed was that using the language model led to significant assistive effect and improvements in the diagnostic accuracy and reasoning of the clinicians. At the same time, we also saw that clinicians with the help of language model has a performance below the language model alone. So this observation suggests that there is more work that's needed to on the modeling side and also on the UX side to make these models to be more useful to the clinicians. While many caveats apply, zooming back, I think what this study points to is that very soon the standard of care will no longer be a doctor at home, but a doctor aided by a language model specialized for the safety critical medical domain. So on the biomedical discovery side of things, this is a very interesting collaboration that we had with Stanford, where we asked ML4H to generate new hypotheses about the gene phenotype association for hearing loss in mice. Here we just give a list of candidate genes and also a free text query, and ask the model to pick the top one, most likely causative gene to the hearing loss phenotype. And this led to a new discovery of a biogenic model for spontaneous hearing loss in mice. I think this is a very fun demonstration of how language models might accelerate biomedical discoveries. And of course, we are doing biology experiments to verify the findings in mice. And this brings to the question of what is the North vision and what is the future. Very excited that we have some ongoing work on some of the topics here, looking broadly at how large language model-based AI system can help advance our knowledge of biology and medicine. For example, like drug discovery. And I think building an AI doctor takes a lot. We want the model to be able to be fully interactive, conversational, and it will be a multitask system that can interpret and encode multimodal medical data using language as a scaffold. We also want the model to be able to perform medical reasoning for diagnosis, treatment, planning, and beyond. Some of these capabilities that we have worked on, but some others like augmenting the language model with retrieval, grounding, and tool use that we are working towards. And since medicine is a safety critical domain, and there are broader considerations like safety, fairness, privacy, and real-world validation that still needs extensive amount of work. I think the idea of world-class AI doctor in the pocket of billions is no longer a science fiction, and this is what we are shooting for. But in the process of doing that and encoding the biomedical universe, I think what we are going to be with is not just an AI doctor, but also an AI physician scientist. And it can not only help democratize access to care, but also help us advance our understanding of knowledge, biomedical knowledge, design better therapy, and also scale personalized medicine to people worldwide. And this is work done with my amazing teammates and many more across Google Research and Google DeepMind. Thank you.
Thank you. We'll now move on to the panel discussion. So I would like to invite the four speakers to come up to the stage. And Luis will be moderating the panel while I welcome the audience to take questions.
Check. All right, this is also working. So we still have this wonderful podium that we also had last year, which makes it possible to see our nice guests, but you can hear us, I hope. So my name is Luis. I'm head of machine learning at Photon and a late-stage PhD researcher based in Germany and Switzerland. I have the pleasure of moderating this panel today with our nice speakers on generative AI and LLMs. And my feeling is a bit that there's so much enthusiasm on the stage about generative AI that my job will be to kind of bring the energy down a bit. So I was thinking, to loosen things up a bit. And by the way, the format is similar to the morning session. So we will have a bit of discussion, but ultimately the chance is for you to ask questions. So don't be shy. I think Shampoo already has the mic ready for you guys. and ask questions, and we will try to integrate it in the discussion. But yeah, maybe to start us off, let's maybe think a bit also about the limits, and then we can work our way up back to the enthusiasm towards the end. So one of the questions I sometimes have with generative models and synthetic data, in particular medicine, is something that Marinka actually touched upon in her presentation. Is this weird configuration that generative models and synthetic data, they would be very useful in settings where we have very little data to begin with, right? But a lot of the very high capacity models that we have nowadays, they need a large amount of data to kind of get started. So how do you see this problem being bridged with methods like the knowledge bases that you presented or other ways to do it? So how can we kind of overcome this ambivalence that we often observe, especially healthcare? So feel free to go around and maybe give your opinion.
Maybe I can start here. This is a billion-dollar question essentially. So a couple of ways we tend to use to tackle this is first synthetic data, right? So there is it's an increasingly interesting topic to complement existing data with synthetic data, and then even more relevant are solutions that allow to link existing data sources in a way that data owners don't necessarily have to give up their right to the data. They don't have to fully open source the data, but aspects that are relevant to the use case can be actually linked. We see this quite a bit in the pharma sector with failed clinical trial data sits on the shelves, but it's being connected to other data that maybe sits in other sources. It can be used for very interesting post-mortem studies or even finding other use cases, repurposing of data using some of these models. So data linkage, synthetic data, those are some of the immediate fixes, I think.
Thank you. Marinka?
Yeah, a great question. I think here what we could first think about is what's the purpose of synthetic data in our use cases. So in the project that I mentioned in the model Shepherd that was designed for rare disease diagnosis, the use of synthetic data was mainly to train deep learning model because there simply is not a sufficient number of patient cases per rare disease that one would be able to train reliably a deep learning model. So how to generate synthetic data that is useful for model training, it's a great point. Usually the way we approach it is through either demonstrations or incorporating prior knowledge into the design of a simulation or data generation pipeline, which effectively means regularizing the model heavily in order to make it such that it can steer in a controllable or still steer the design or generation of a synthetic data point in a way that is controllable and grounded in prior knowledge. The way we achieve that nowadays is through retrieval augmentation techniques, through collection of user preferences and then optimizing the model in that way, or regularizing the generation process by limiting the generation space to prior knowledge, often represented in the form of knowledge graphs. The second use of synthetic data that I see is more on the output side in terms of how synthetic data that's being generated can serve as some form of virtual simulator. And I think there are many interesting cases for that in healthcare, even more so in computational biology, where the synthetic data that's being generated can be thought of as some form of virtual simulators, for example, simulators of cells, that would then allow for examining or testing hypotheses of how a specific molecule or cell would behave under different kinds of perturbations. And so that kind of simulation traces could then feed into the model if trained in a continual manner to increase the potential space of the hypothesis space that the machine learning models are generally being trained on. This is particularly important in the context of chemical space, which has 10 to the power of 60 molecular compounds that might be drug-like molecular compounds. Yet humanity has around 7,000, so 10 to the power of 3 approved drugs. So imagine what would we be able to achieve if we would go from 10 to the power of 3 to just 10 to the power 5 or perhaps 6. And it would require just expanding the current space of accessible chemical space by just a bit, right? And so potentially synthetic data there can help explore or expand the part of the hypothesis space that is accessible to machine learning models. And so I think that's also an interesting use case for synthetic data in this domain.
Yeah, I totally agree with what you guys just said. I think the use of synthetic data in medical domain is very critical because medical data is very difficult to obtain, and also oftentimes when you get a medical regular data set, you only cover a very narrow range of conditions. So that really doesn't really generalize well and expose the model to a variety of different contexts. But I think another usage of synthetic data is also for evaluation, like we did in the genetic discovery paper, where we synthetically curated the question and also using the existing knowledge, like the prior knowledge, that the answer we have already been verified with the experiments to see if the model can actually perform this type of task. And also from the training perspective, this is where we can leverage and integrate expert knowledge. So we can generate synthetic data, and it makes it easier for the human labelers to do rewrite compared to asking them to do that from scratch. And also we can use self-critique, self-play kind of approach to iteratively improve the quality of the model and the data.
Yeah, I agree there's a huge opportunity for synthetic data and evaluation specifically. So kind of in the space of clinical NLP, it's often very difficult to make the text kind of a public benchmark. So compared to a chest x-ray where you can look at an x-ray and not be able to identify like that's Monica's x-ray, if you read my clinical notes, it sometimes says like, her research involves this, because the doctors love complaining about their EHR to me. So the clinical notes often contain a lot of really specific information that's very identifying. And as a result, we've had a real lack of benchmark data sets in clinical NLP because, if you're trying to make a summarization data set, you would have to release, a full discharge summary or a full, we don't have huge publicly available clinical NLP benchmarks. And I think synthetic data can allow us to do so because it's really infeasible to ask a clinician, can you write 1,000 documents for me? And it's really hard to do. And then at the same time, I think given that we might have limited amounts of data, I think looking to the sorts of data sources that exist in healthcare that I showed earlier from patient health resources that are online can help supplement other data sets.
Thank you so much. So let me do the quick scan glance. We have audience questions. There we go. So now it's good.
Hi. So I also work on rare diseases, and we have a lot of omics data sets with millions of features and not clear semantic meanings. So I want to ask the panelists, in that case, do you think there will be a day that we can create large language models like ChatGPT for omics data with the challenge that data has?
Great question. So yes, there are already ongoing efforts on adapting large language models to single omics and multi-omics data. Quite lively research field is concerned with training large language models for single cell gene expression profiles. This is a great area that's cusp of benefiting from LLMs because we have now the order of not only hundreds of millions, but hundreds of billions of cells and full genomic transcriptome for those cells across an entire range of genes and how they activated are there in the cells. So the data sets are sufficiently large to start training these language models. The main challenge that the field currently has is that multi-omics data inherently is not ordered. And so large language models currently rely on transformers, which require that your input is a sequence. So if you look at single cell transcriptome of a cell, it's just a high-dimensional vector of genes and how active each gene is in a cell. But there is no inherent ordering to those genes. So current state-of-the-art approach in the field is kind of more or less a hack, which is you take a gene expression profile, you transform real valued gene activation values into rank order differential gene expression, and you use rank order to define the ordering of genes, and then you can train transformer like LLMs. I think there is just tremendous opportunity for algorithmic innovation here in the sense of thinking hard about what are appropriate self-supervised objectives. It's not necessarily just next token prediction that are more suitable for multi-omics than what has been developed for NLP. And existing work is mainly direct translation of NLP work into multi-omics domain, trying to pre-process the data so that it would fit the expected sequence-based representation for transformers.
Thank you so much. I have another question. So I want to ask the panelists, what do you think about, say, integrating mechanistic knowledge into LLMs or potentially generating mechanistic knowledge from the language models?
I think she's asking about what we think about mechanistic knowledge and training mechanistic knowledge in the model. I can start perhaps. So the way I understand mechanistic knowledge is those are these compact, distilled descriptions of certain scientific biological findings. Ultimately, that's the goal of science, right? So science is the discipline of acquiring and building new knowledge. The knowledge at the end of the day comes in the form of almost like theorems or compact statements that describe central dogmas or that give kind of describe key mathematical equations and so on. So it's a really exciting direction to think of it. The way it's being addressed nowadays, it's mainly through questions related to compressing LLMs, low-dimensional model distillation. There is an interesting research line in the AI for science space using symbolic regression models to actually extract symbolic expressions, candidate laws and theorems that can that really provide mechanistic explanation of a data set. I think that DeepMind published a really cool paper on how these kind of symbolic regression models can guide the intuition of mathematicians, and they showed that they were able to prove a couple of theorems on that front. I think it'd be great if other fields could benefit from that as well. I'm not aware of major successes, so it's more or less an open field.
Yeah, I think one place where this is interesting is like retrieval augmented models, where we can kind of guide the knowledge that the models are being trained on. I think one other area that's kind of interesting that I've seen papers pop up in is instead of necessarily asking the model to create a final answer, it's using the model to maybe answer smaller sub-questions. So features X, Y, Z. So, you know, does this patient have attribute A, B, and C, and then plugging that in to another model. So instead of necessarily asking the model to do all of the reasoning itself, you can ask it to do subtasks that we know mechanistically are correlated to the answer that we care about, and then get those sub-answers and then combine them either with a smaller machine learning model or otherwise.
All right, I think the ice has been broken.
Really interesting talk. Thank you very much for the panel. I have a question regarding LLM in the sense of it is a very, very fast-moving field. It is very computationally expensive, and some observational things we do in one model may not apply to another model. For a smaller model, it may be the right thing. For a larger model, it may not. So in this sense, when we use LLMs for healthcare applications, which is mission critical, what are some suggestions you gave? For example, should I try the most recent model, the biggest model possible, or what are some good tips you have in this experience?
Yeah, I think at least personally, the approach that I am taking is working closely with experts. So you first have to understand the use case, and then think about in the context of the model what capabilities that you can offer. As an example of the scientific genetic discovery, you would think it's really wild just to ask the model what is the most likely causative gene for, let's say, hearing loss. And what we have seen is that the model generates a lot of positive. And it also highly dependent on the choices that you gave. So what we had to do is we have to use expert knowledge to really narrow a short list for the model to generate the response. So I think first try and see what comes out. And another drawback that exposed from doing the genetic discovery exercise is we might have some issue with the tokenizer of the model, so it cannot really recognize the gene symbol correctly. An example would be MED1 is a gene name, but MED is also a shorthand for medical, which appears everywhere in the training corpus. So this really causes confusion for the model. If we don't test it, we wouldn't even know these problems.
these are some of the considerations. But if you're actually intending to build something with it that lasts, I would also look at the dependency on who provides that model. Is this something you can rely on further down the road? Will it go away? Also, larger isn't always better, right? So the scaling laws of models versus the compute power that is needed to actually exploit the size of these models have been a little misunderstood recently. I think DeepMind had a good paper on this not so long ago. So it depends on what you really want to do. Like you said, the use case is utterly important on choosing the size, but really not just the size, but also the type of model under which you can access it and actually build with it. So Hugging Face is always a good place to start looking at finding for alternatives to the usual suspects.
If I connect to that, I'll make 2 points. So first is, I think we are perhaps neglecting a bit human-centered AI aspects. So for example, in the context of our KHGNN study, what we found was really important in order for clinical researchers and biomedical scientists to start exploring and using the model is to think very hard about how to present and expose model outputs in terms of predictions it makes, generated explanations, mechanistic paths, and all that to human experts who might not have coding experience. And so the first simplest way to do that nowadays is, of course, create a Hugging Face space, which is really a great way now to put together a number of radio widgets that allow you to present your model and model outputs to the broader audience. But it goes beyond that. For example, we have done a usability study with THGNN and found that the way one visualizes explanations of the model in the form of linear reasoning paths or subgraphs has kind of fundamental significant effect on whether users were able to, first, how much time it took them in order to make sense of prediction that the model made, and second, how easy was it first for them to decide whether a prediction that the model makes is sufficiently trustworthy that they would be willing to go and do a clinical or preclinical experiment or put some resources behind that prediction, validating that prediction, versus just moving on. And so the way we are designing user interfaces that allow users to interact with AI models and provide feedback that potentially could lead into improvement of the model is really important. And I often see that users, what they do first, they want to effectively test the model on a couple of checks that they know are true based in their field or area of expertise. So that requires us as model developers to provide these kind of interfaces, and those often go beyond kind of trivial interfaces or just CSV files or just some kind of text box and so on. I think this is really an exciting field that requires much more research. The second point that I would make is that one question to ask is, well, which model should I choose? The biggest, the smallest, the open source, the closed source? But one answer to that question would be perhaps like a number of models together. And there is an increasing excitement around the agent systems where you might have a system of multiple LLMs, or this one LLM that plays the role of different individuals in a team that interact together to solve a complex problem, and they can also use tools, and they can also have access potential to other down the line experimental platforms. And that allows you to think about integration of tools in the sense of algorithms or models that were developed and are established in a given field. So for example, computational biology, BLAST is an algorithm that has multiple decades here of proven utility, and it can interact with LLMs in a way. And LLMs can then cooperate and be integrated and kind of instantiate under different conversation patterns in order to take a complex problem, break it down, and potentially solve it, as kind of Monica mentioned before.
Hi, so regarding backbone M, I didn't see any experiment in the paper where you can synthesize all the different modalities, like medical modalities, such as you can upload genetics, radiology, and text report, and then a certain accuracy in a certain task increases. So I just saw, for example, just text and image, not all of them across. So I was wondering if you have to make some architectural changes for that to happen, or are you planning to do some experiments like this in the sector?
Oh yeah, that's a very good question. I think we didn't really make much architecture change in the version. It's more like a feasibility study. So even for the genomic variant calling task, we kind of have to convert the sequence data into the format that is compatible with the vision transformer. But I think that points to another different approach to achieve a generalist AI system, which is we have these modality-specific encoders, which is very important for medical domain. Like a mammography and CT, they are completely different dimensions. So underlying the POME architecture is the flexibility that we like. You can interject the multimodal tokens into the text domain easily. So we can easily augment that, like grafting different modality-specific encoder into the language model backbone.
Thank you for the talks. I was wondering, you mentioned several times that sort of generative AI may be trained on data sets that are labeled in different ways. They can be labeled by clinicians, or they can be confirmed with clinical. They can be labeled in different ways, and there can be mislabels. And how can we sort of, as a community, ensure that mislabels are not propagated further into generative AI, and sort of you're essentially learning on incorrect data and providing an AI where to make mistakes? What do we do about this?
You guys go, so don't be distracted by my pointing.
I mean, I don't think there's one kind of simple answer here, but I think there's different. I think it's maybe useful to kind of break down the kinds of data that go into LLMs. So there's the kind of pre-training data that's not, there's no labels, but it's just the kind of open text, and then there's kind of instruction fine-tuning or human preference labels. So I think on the so I think in terms of pre-training data where we're just kind of training on text, there's different ways to sort of, and this is something that like search engines have been doing forever, trying to understand what websites might be more reliable and use those specifically in your pre-training and kind of weight those higher. In terms of kind of instruction fine-tuning and human preference, I think, you know, what a correct label is on kind of those preference questions is actually, I think, a really difficult one. So I think, for example, I think like a common refrain I hear is if you ask two doctors the same question, they'll give you 3 different answers. And this is something that I found pretty commonly like among deployment is that there's not 2 answers that a single doctor will, you know, there's not a single answer that 2 doctors will necessarily agree with because everyone has kind of a different workflow that they've sort of developed. So I think there's questions of how do we personalize things to work for a specific clinician's workflow. So for example, you know, if you even look at clinical note writing styles, they can differ significantly. So if you're trying to do something that helps with that task, for example, if you always generate in only a single style, another clinician is going to find it kind of clashes with their workflow.
Yeah, just quickly to also add to that, we often see that it's vastly underestimated how much effort it is to do these kind of things, right? So it's not that the model out there is a self-fulfilling prophecy, it's actually the labor burden on these kind of labeling tasks, data curation, they're actually massive. And it's something that needs to be taken into account in planning an experiment. So just comment on feasibility of all of this.
Just want to add one more thing. There's actually methods that you can basically do attribution on your training data, but it's specific for tasks, so you can use to detect the like bad training examples.
Okay, we have one more audience question.
Yeah, thank you for the interesting talks. I kind of wanted to maybe connect a bit with the first panel talk session. So I was wondering, these models seem very exciting, and yeah, they have a lot of exciting prospects basically. But how are you ensuring, like, how are you going to ensure that they get adopted in a clinical setting? Because I feel like traditional models are not very likely to get accepted. I mean, there's a lot of projects that seem very promising and then kind of didn't get a clinical implementation. And this seems, kind of because of the kind of amount of training data and kind of the opaqueness to me that it's maybe a harder challenge even, and maybe also to the responsibility like questions. So yeah, how in general are there kind of guidelines or kind of a plan to get this into a clinical practice and do actual maybe a clinical study with this? Yeah.
Yeah, so I think there's some existing deployments, and I think what we're kind of seeing is this inflection point where there's, I think, a huge amount of interest from clinicians in large language models in a way that I had never seen before. So I remember giving a talk on language models in like October, like pre-ChatGPT, and then as soon as ChatGPT hit, I got like emails being like, actually, I want the slides now. So I think there is kind of clinician, kind of grassroots interest in a way that we haven't seen in the past. But then I think one thing I want to talk about is, I don't know if the goal is always necessarily to get large language models in, but I think one thing that's really important is there's these ideas of intrinsic evaluation and extrinsic evaluation. So intrinsic evaluation for a piece of generated text is something like, is it factual, is it concise, and kind of a set of standards. But then when an extrinsic evaluation is saying, if we actually insert it into the clinician's workflow, is it helpful, does it guide them, does it improve kind of their workflow? So I think when we think about adopting this technology, saying that it's like factually correct is not sufficient in my mind versus trying to understand what are kind of the downstream effects more widely when actually kind of integrated into our workflow.
So great question. I'll make 2 points. So our work with rare diseases is really motivated by the current lack of computational tools for that area, because it is on one end so challenging to provide and develop models that would support matching of rare disease patients to therapeutic interventions. It is not necessarily features to like pharmaceutical companies because there's no financial incentive for them to develop new drugs from scratch for rare diseases because the patient populations are too small for developing new drugs. On the rare diagnosis side, the problem is so challenging that off-the-shelf deep learning models don't work or cannot even be applied in many ways. So there is this great need or kind of really unmet need in the field. So because of that, we find that our collaborators are then really very excited about having tools that they can prototype, that they can rely on to pursue medical research in this area. And kind of it goes back to what Marinka said with respect to really being a collaboration between machine learning scientists who are excited about their models and when their models are deployed, but not only that, also biomedical scientists on the other end seeing a potential value of those models and then can meeting computer scientists in the middle. And I think that's kind of fundamentally different than what was perhaps 5 or 7 years when I remember being a PhD student and I was knocking on the door of biologists and saying, I have this cool algorithm, would you be willing to apply to your data? And kind of I did that from going from one door to the next door. And this is not, it's not like that today anymore, where it's almost the opposite. And so this means that certain barriers that were there before are now kind of not there anymore. And there is much more there are many more opportunities of direct communication and collaboration in that regard. I think there are also, regarding deployment, the needs for creating this meeting point between those who develop algorithms, those who know what are the big problems and bottlenecks that need to be solved in the field. That was mentioned in the earlier panels today. So to address this effect, we founded Therapeutic Data Commons as an initiative that can provide this kind of meeting point between AI scientists and computational scientists for drug discovery and development. And I think there are several other kind of coalitions for certain medical problems or disease areas that I think are very important to nurture and grow in the future.
Yeah, just briefly to add to that, right? Drilling it down to reality, the strongest voice that you can have if you propose to develop a solution that you intend to change the clinical workflows with is the voice of those who you intend to commercialize it to, or you intend to give it to, and they saying, we need this is our problem, right? That's what everything else starts with. And it means so much on how you then actually go about this journey in a consumer-centric design kind of way, keep your users in the loop as you develop your algorithm, as you validate it, as you refine it. That's not a thing where you essentially go, thank you, so this is your problem, I go off now, and a year down the road I'll emerge from my lab, and here's the solution. This is just never how it works. So it's very iterative, very closely knit, collaborative environment, and it needs to start with the user who says, this is my problem, this is what I want to solve, not the other way around. That this is some shiny thing in the world of AI. Would you like to have a closer look? Well, sometimes that works too, but the predominant version is where you really identify a pressing problem in the real world, and then think about if AI can solve it. And very often, actually, this is sacrilege here. It is not AI sometimes that solves the problem better than anything else. Right? It's something to think about as well.
Part of it about one of the most difficult thing to do is explain the pathology of the disease using any technology, not just AI. So my question is, with generative AI, where there's one way of thought says generative AI models hallucinate all the time. It's just sometimes that hallucination must right. So that limits the usage of generative models in medicine, especially if you are trying to say like how the pathology of disease works. So is that the right assumption?
In some way, yes, it's right assumption. So that's why there are techniques to mitigate that. And examples include instruction tuning to align the model outputs to adhere to human instruction more closely, or retrieval augmentation to make sure that the model hallucinates less by being optimized so that it also performs a retrieval correctly from a medical knowledge base of prior knowledge. So these are strategies that have been shown successful to mitigate the problem of hallucination. I would almost kind of make another point here that it really depends on what are the use cases that we're discussing. If those use cases involve research, so not clinical medical deployment or use cases that involve high-stakes human decision-making that would affect human lives, then the use of generative AI might actually can help with ideation of new research projects, brainstorm research ideas. And so that has been starting to see some adoption in the field in the context of developing virtual simulators of cells or organs or digital twins that would serve as a way to simulate certain behaviors at time scales or types of tissues or types of cell types that are generally not accessible in regular medicine or biology. So in that regard, the generative AI and to some extent potentially hallucinations when controlled could be considered a feature, not necessarily a bug. I know that there is a huge Twitter war on this topic taking place this weekend. It's a completely different story for clinical decision making, where those hallucinations should be kind of controlled, models not run in an autonomous manner and all that.
Yeah, I totally agree. This is heavily use case dependent. I'll give you an example where hallucination might not be a bad thing, which is the genetic discovery. If you have a model that only surfaces the candidates that are heavily implicated in the scientific literature, then they are not novel and interesting enough. But if you generate completely new things that is not really mentioned in the literature, do you consider that as a hallucination? Probably, but sometimes it might also lead to a complete novel discovery.
And I think one other thing I want to say on the topic is, I think there's a lot that human-computer interaction can teach us in terms of how do we actually present and design interfaces. And this is obviously use case dependent to kind of mitigate that design. I don't think every solution is going to be machine learning, and I think we have to really, there's a lot of people in the kind of interface community who've been thinking about these sorts of questions, and we should sort of lean on that expertise as well as a community.
One more question here.
Thank you very much. There was a question I asked in the earlier
panel discussion, and I'll ask you also. The issue has to do with when we are dealing with large language models, you basically train your models on available data. And so in situations where one, the data is not representative, and two, the data is not available at all, how do you ensure that where there are biases, it doesn't heighten existing stereotypes, and you don't develop models or develop solutions that are tailored towards only a particular group of people? How do you ensure that?
Okay, I can start. I mean, I don't think there's I think I've said this before, there's not a simple answer. I think this is kind of a large question. I think the first step is understanding when it doesn't work. So I think before we necessarily try to come up with something that works generally, I think really as a community understanding when things aren't working more generally and what populations we expect it to work or not work on is really one of those first steps, and really understanding what is the data being ingested in these models. Past that, I mean, I think there's ways to sort of augment data, and as I was saying, like look at other data sources beyond maybe the EHR at one's institution. And I think the reason that these general language models are doing better at kind of analyzing an institution's data without having seen it before is because it's the information online from these patient and clinician forums are not, institution specific or United States specific, and instead kind of exist in a large number of ways. But I think there has to be a significant amount of evaluation to understand the failure modes.
And then have the guts to call it if you realize that you don't have the data to do it right? So that's a really important lesson, right? There might be like a cool model there, and others might have done a really good use case with it, but if you realize that the data that you have at hand is just not supportive for a use case because you identified these risks, then just don't do that, right? And be transparent about it. Then you can work around creating synthetic data or teaming up with others who have data that could help out. But there's nothing worse than these high-profile failures where things really start to develop a viral life and take down pretty much the opportunity to develop this in peace and quiet and with enough data at hand over a longer period of time. So in healthcare, things don't work like the classical Silicon Valley move fast and break things paradigm. That's a recipe for disaster. So that's just something to keep in mind.
Of course, rigorous evaluation and benchmarking is really important, and it's now become a standard to stratify model performance by it being important groups or population groups and study how model performance changes as a function of the volume or the amount of data that we have for a certain group versus other interesting properties. I think what is exciting here in the field in the area of model auditing and data evaluation, bias detection is also slice discovery, which is this notion of using techniques to automatically find what are subsets of the data that the model performs really poor on, really well on, because otherwise we often kind of do checks for more or less variables or properties such as demographics or structuring patient population that is clearly already established, or perhaps some prior knowledge that there might be bias, but there might be things going on that we are not even aware of. So slide discovery methods can help you identify what are subsets of the data that the model performs much better or much worse than on the rest of it. I think what is an interesting use option is also to train models in such a way that sometimes they would refrain from making predictions. So otherwise the model can always make a prediction. And so it's important to, based on uncertainty quantification, based on techniques that can estimate confidence of the model, which is a separate problem on its own, just allow the model to refrain from making a prediction and then ask humans for second opinion and not make prediction at all using LLMs when that is the best action to take.
So there's a news that GPT-4 is getting lazy, and this is not the first time that this happened.
So, I mean, as a researcher, how we can make sure that our work is reproducible when we have to build our works around those proprietary models, and then they are changing even without us knowing what has been changed.
Oh, I don't use it.
Yeah, it's a struggle, I would say. It's a struggle sometimes planning research projects with PhD students, and you're planning a project in such a way that, that it's unclear whether it will still be relevant in 3 to 6 months. So the strategy that I see for my students in my group is that we force ourselves to ask a question for every new research project. Why are we the best research group in the world to study this question? What is our competitive advantage? Some unique insight into biology or medicine of the problem, some unique partnership or collaboration or data sets or resources that we have, or some unique algorithmic capability. And so then we go after those projects and after those problems, rather than kind of go and chase every day what are new models that were published and released on Twitter, because that can be quite challenging for both students as well as the trajectory of a research program that is being developed. Reproducibility is, of course, a very big problem. Kind of a short answer would be we should do this in open science manner, but then we know that this will not happen because model weights present a competitive advantage for commercial providers of these models. It's hard to say. Historic model checkpoints would be very useful, that we can at least refer to them in kind of manner that's somewhat is reproducible, or like at least we have some provenance, but not really reproducibility. Yeah, it's a challenging problem.
My hope is that actually regulation will, or upcoming regulation will help that through the transparency rules that we see in the EU AI Act, and that there will be an increased scrutiny around, well, not just asking, but forcing for transparency and reproducibility in this work. Maybe it's a bit of a hope, right? Because some of the geographies might not fall under the same jurisdiction, and others might just not develop products that way. So it's something that probably looks a little different in the research world versus the commercial world, but it will be something that that will remain a problem for a longer period of time, I suppose.
Thank you so much for the great insights. And I would like to ask the panelists, previous talks we've mentioned there's a long way to go to build up AI doctors. There's a lot of aspects we need to work on, like safety and privacy and understanding the reasoning behind the diagnosis. So I want to ask, what is the most important part you think we need to work on? Or what is the most challenging one that we need to tackle right now? And if we will really have like an AI doctor in the future, what kind of form do you think it will be? Is it still like assistant doctors that will help the real human doctors to take a lot of parts of the work, or is it going to replace the human doctors and do all the work?
There are many answers to these questions, and I think the perspectives offered this morning were very illuminating. To add to that, I would say contextualization is what we found really important. So to have models that can dynamically adjust their outputs based on the context or environment in which they operate. So what that would mean that to take into consideration the background information about the disease, or background information about the patient, or whether a drug, when predicting whether a drug will work, take into consideration about what is the mechanism of the drug, what specific parts of the human body does it affect, and then the model taking that context that are often dynamically specified by users in the form of prompts into account when making predictions. That's something that I feel is quite important. I'm very excited about this idea of potentially have agent systems, even if it's just a single LLM that plays different roles, because then you can have in the context of drug prescription, then you can have an LLM that plays a role of a safety officer, and kind of that safety officer would then suggest to the doctor, who's a human doctor, and prescribes a drug, well, but perhaps you should consider that there might be a contraindication or an issue with toxicity of that drug for this specific population that your patient belongs to. And so that is kind of an opportunity that to me seems more exciting in the short term than being fully autonomous systems, especially in the context of doctors. I think that in the context of scientific research, fully autonomous systems and self-driving labs in particular might be easier to implement than AI doctors, but even those systems are incredibly hard and challenging to implement and address. But then going from those autonomous AI scientists to autonomous AI doctors just seems to be another level of incredible complexity that as a field we would need to address, and it goes well beyond computer science and machine learning, as has been mentioned before.
Yeah, I mean, I don't think I necessarily see like autonomous doctors as a particularly short-term goal. I think, and one of the things I was trying to talk about earlier was that I think often when we do machine learning and benchmarking, we have a set of almost fixed inputs and then outputs we're trying to predict for, whether that's a diagnosis or a classification. Whereas medicine is a lot more of a ping pong of you're now trying to get another piece of information. And it's a much more complex sort of with, 300 small decisions that are being made in the diagnosis process. So I think there's places for models to assist in what's on certain steps of that, but I don't think we're anywhere close. In terms of what's the most important thing, I think there's several things that you mentioned that are all necessary, but I think kind of the human-centered evaluation is going to be really important, and before I think anything is ready for deployment.
Alright, so some of you know my reputation for being a super hard time cutter, and we are beyond time, so I have to cut at this point. But I learned today that if you have a wonderful crowd and a wonderful panel, you can just go full autopilot. So this is applause for you guys and our nice speakers, please. Also, we have some lightning talks. So people who have lightning talks, come up here. If you have more questions for the speakers, I think they will be around, so feel free to follow up. And then afterwards, we have a post.
Okay, so we know that drill, right? So 2 minutes for each talk, and after that, I'll start talking about your talk, so you don't want to butcher your work. So we'll start with the battle line and then go to that.
Hello, my name is Gonzalo. I'm a PhD student at Stanford University, and today I'm excited to share with you our work on Milind, a clinician-generated data set for instruction following with electronic medical records. More and more papers are claiming that large language models are reaching expert-level performance on medical applications. Here we can see the progress of large language models on ML4H, a very popular benchmark data set. However, does reaching expert-level performance on multiple choice exam-style-like questions means that large language models are ready to address clinician needs at the bedside? Well, let's do some comparisons. In ML4H, questions are paired with patient vignettes in which all relevant information is provided. Furthermore, there's a subset of questions, answers that are also given to the model. In contrast, in a real clinical application, medical doctors have to go through electronic medical records in order to first extract relevant information, and then after that, answer a question. We tried to mimic this in Milind by simulating this setup. We first solicited questions and instructions from 15 practicing clinicians spanning 7 different specialties. We then aligned those instructions with electronic medical records from Stanford Healthcare. Lastly, we asked clinicians to generate gold standard answers to those questions and instructions grounded on the electronic medical records of the patients. And now that we have these questions, let's see what clinicians really want from a large language model. And it turns out that conditions want large language models to do retrieve and summarization tasks, in contrast to diagnosis support, also known as MEQA, which covers 3% of clinical interest, instructions of clinical interest. Lastly, let's evaluate the performance of large language models on Metaline. Well, it turns out that the best large language model, ChatGPT 4, has high error rates of 30%, indicating that there's a huge room for improvement. Thank you, and make sure to visit our website and our poster session to see more information about Metaline.
Next up is Generative.
Thank you very much. Time things today. So, I'm super excited to be here. My name is Michael Moore. I'm a postdoc at Stanford CS with URLS kit. I'm maybe one of the few medical doctors in the Gates building at Stanford in computer science. So I'm always worried that I one day need to run, and because my medical skills are a few years ago. So when I doing my PhD, I worked a lot on developing deep learning models for like EHR, time series, and so on. And I got frustrated that those models just don't really know about medicine, about physiology and pathophysiology. So when coming here to the US, I developed this vision that we basically want to get all medical knowledge from different modalities, images, text, and it will go way beyond that, into a single model before the model is even trained on clinical patient data. Today, I want to briefly mention that we are taking first steps in this direction. MedFlamingo is a medical vision language model with the goal to flexibly ingest different modalities. Here we focus on text and images, such that you can then generate text based on that. And what we do to achieve this is we first adapt a pre-trained OpenFlamingo model on medical literature, both images and text. And we then show that we can do few-shot generative visual question answering, and we run a human evaluation study with clinicians. This paper, or this method, unlocks multi-model and context learning, which I find quite exciting, and as we heard in the panel before, it's a skill that's very important to now really unlock the capability of models to learn from few examples, and I believe we need to be able to do that across modalities. And you can imagine numerous applications. We can do multimodal retrieval augmentation with that. We can let models generate rationales on the fly, and many more things. I'm very happy to talk to you at poster 14.
Models to predict 3D late mechanical activation.
Motivation behind our work was to locate an optimal scar-free pacing site, which is vital for the success of cardiac desynchronization therapy. And this is usually a region with late mechanical activation of the left ventricle. Though several learning methods have been introduced to predict 3D LMA, given either the sequence of cardiac MRIs or the derived strain values, these however consider either 3D interpolation or a standard one-size-fits-all clinical reference model to represent these maps. This results in suboptimal predictions. Moreover, the current generative models do not consider the shape of the myocardium while performing 3D volumetric reconstruction. So in our method, we make use of a jointly trained network that learns the mean atlas as the shape prior that's used during this volumetric reconstruction given the sparse 3D slices. And following this is an interpolation and alignment method along with the strain matrix to obtain the 3D LMA map. The quantitative results show that our reconstruction network outperforms some of the existing state-of-the-art deep learning models used for volumetric reconstruction. And the qualitative results show that our our method provides a more accurate binding between the 3D enemy that's predicted and the individual patient's ventricular anatomy. If you want to know more about your method, please visit poster number 15 in the upcoming session. Thank you.
Hi, my name is Divya, and today I'm talking about our work on coarse race data, which is joined with several others, including my co-first author, Raj. Okay, so many recent papers have shown that clinical algorithms can work differently for different race groups. For example, on the right, we're plotting the performance of a risk score on the x-axis. And in this case, the risk score predicts whether a patient admitted to the ER will ultimately be hospitalized. And as you can see, this risk score performs differently and performs better for some groups compared to others. So many fairness audit studies do something like this plot, in which patient race is coarsely coded into these broad, census-recognized race groups. And in this work, we ask whether coarse race really tells the whole story. So let's take, for example, patients coarsely coded as Asian. Within this group, some patients identify as Chinese, I identify as Indian, etc. Across the 4 commonly studied coarse race groups, we studied 26 granular race or country of origin groups, listed here on the right. And when we fill in the plot on the right, we see that there are indeed many granular race disparities that we would have completely missed by using only coarse race data. In fact, we find that there is often more variation within the coarse races than between the coarse races. So to reiterate, many fairness studies use this coarse race variable, and if this setting is anything like the ones we study in our own work, they may be missing important demographic variation that we should be taking a closer look at. So I think there are 2 important implications of our work. The first is that we should strive to record and release granular race data. And the second is that we, as researchers, should strive to analyze disparities in the context of granular race data wherever possible. So the paper has many more experiments to verify the robustness of our results, and I look forward to talking about these in the poster session. Thank you.
So I wanted to talk about prediction models and how they're used to inform decision making. So suppose you're in the following situation. So suppose we're in a setting where we build a prediction model to decide to figure out who will have a good or who will have a bad outcome. And suppose we have 2 groups and we predict that one of the 2 groups will have a better outcome than the other group. Now there's a lot of models in the medical literature that try to do this, and they claim that you can make decisions based on these predictions. What we show in this paper basically is that if you now evaluate these models, even if these models are very accurate, both when you're developing them and also once you have deployed them, these measures of how good these models are predictively might not say anything about how good they are in terms of the decision they're making. And so what you might have is that because you developed this model in a particular data set, in the data set you might have very good predictive performance. But it might actually be the case that because of these decisions that you're making, you're actually causing harm to one of the groups, as we have in this example. But in this example, if you closely look at it, turns out that in this example, you still have very good predictive performance in the setting where you applied the model. And so what we found in our model is that what we basically try to do is give a formalization of what it means to do harm for these models. We include what we mean by something called self-fulfillingness, which is related to this discriminative performance. We characterize when these 2 things occur together, so basically when we can cause harm while not being able to detect it. And what this basically means is that a lot of the practices in the literature are maybe not so great. So what we find is that having good predictive performance might not be a very good indicator of whether you're doing harm or not with your decisions. And so something should be done. Ultimately, I think the main message is that you can still build good models to do decision support, but what you have to do is really treat them causally, and if you don't, you might run into issues like we covered. Thank you very much.
Hello all, my name is Chris Williams. I'm a physician postdoc in the Mutant Lab at UCSF, and I'm presenting our work looking at the use of GPT 3.5 Turbo, or ChatGPT as we know it, to provide clinical recommendations in the emergency department. And in particular, we're looking at 3 recommendations. Firstly, should the patient be admitted to hospital? Secondly, should the patient receive radiological investigations, chest X-ray, ultrasound, and so forth? And thirdly, should they receive antibiotics? So how do we do this? Well, we have 140 million de-identified clinical notes at UCSF. So we took the first notes written by physicians of patients presenting to the emergency department and extracted 2 sections from these notes, the presenting history and the physical examination part. And we use this as input to GPT models using one of the 4 prompts on the right. And so at the baseline prompt, we look at just simply, should they be admitted, should they have antibiotics, and so forth. And we just increase the complexity down to prompt D with chain of thought prompting, let's think step by step. So what do we find? Well, essentially, in comparison to the physician, we find that regardless of prompt, across all 3 tasks, there's a very high sensitivity performance for ChatGPT. However, there's a markedly reduced specificity for all of the prompts in comparison to the physician performance. And this, in terms of accuracy, manifests in substantially reduced accuracy for all 3 tasks. And this leads to the conclusion that essentially ChatGPT is overly cautious in its clinical recommendations. There's a kind of calibration problem. There's a tendency to recommend intervention, and this leads to a high false positive rate. If you'd like to learn more about this or discuss some of the reasons behind this, then come find us at poster 13. Thank you.
Hi, Cécile, I'm a PhD student at the University of Zurich, and I'm presenting our paper for modeling predictive disease trajectories using deep generative models with escalated processes. And actually, in this paper, we attempt to model the underlying generative process of patient disease trajectories. And to do so, we train our semi-supervised temporal variational outcomes model-based model on temporal patient clinical records. And furthermore, we use sparse medical knowledge labels to guide or disentangle related space. So it's a way of introducing medical knowledge into the model, and these labels would correspond to the latest medical definitions of some aspect of the disease, such as, for instance, the severity stage. So by using this generative approach, we believe that we get a more holistic understanding of the patient disease trajectories. We can then analyze the disentangled dated space, use our model also to perform online patient monitoring, because we can predict all of the future temporal clinical measurements of the patients. And then we can also, in a second stage, cluster the latent space to find new disease subtypes. And as a use case, we modeled the organ involvement and severity stages in systemic sclerosis. So in this systemic sclerosis model, we analyzed the learned latent space. So here in these plots, we show the TSNE of the latent space, so each dot represents a patient at a given time. And we overlaid the plots with the values of the different medical labels that we use. So for systemic sclerosis, it would correspond to the medical definition of involvement or severity stage for the different organs that we model. And so on the left, on the right here, we can see that our model, so the guided model, has a higher disentanglement with respect to these medical labels than an unguided model. And on the left, we further overlaid the plots with the other medical labels, so we clearly see that distinct regions correspond to distinct values of these labels. And in the paper, we present preliminary results in which we cluster the latent trajectories that we found 3 main clusters for the systemic sclerosis. Thanks a lot.
Awesome, and thank you. I promise I'll be just a minute. So first, I want to start by saying it's really great to be here and to see the way that the symposium has grown. I think I was a reviewer back in 2017, and then subcommittee chair in maybe even 1 year before, program chair in 2018, and then general chair in 2019. And so now, coming back a number of years later, I'm Brett Boyer-Jones. I'm the chair of ALI, which is the sort of organizing group for both this and CHILL, as well as a number of data challenges. And so first, I want to encourage everybody in the room to get involved, because I think we try to do a good job of bringing people up through the ranks, and that's sort of why I tell that story. The second is I'd like to take this time to thank the organizers. There's a huge number of organizers organizers that go into putting this together. It's no longer so easy as a workshop at NERVs. Now, even things as far as getting a facility are a lot of work, and getting organized and getting reviewers, especially in this time where this work is so hot. So if we could just give a round of applause for the organizers. So Ali only has one employee as well, and she does a lot to support all of us who do the service in sort of our organization. And so if we could give a round of applause to Tasmany, who's back, who has really helped us all to get everything organized. And then finally, we don't have any resources outside of what our sponsors provide to be able to get beautiful venues and things like that. So just a round of applause for the sponsors involved. And so either go to ali.cc or follow up. I think there's going to be an email coming out to everybody. And we'd love to get sort of the sort of next generation involved in organizing these for the future. Thank you.
Hi everybody. We could just like, I think there's a lot of awesome conversations going around. I just want to be really short, do some closing remarks, and set everybody free at the end of the day. Thank you everybody for coming. I think it's been a super fun day. I'd like to take a few minutes to just thank all the organizers for all their hard work that has gone into this event. We had an awesome program team who put together the schedule for the day. I think everybody did a great job. The paper submission process was very smooth for the most part. I know a lot of work went into this. Thanks to the great team for running our open review, the workflow team. There's so much mentorship that has happened in this room. It's extremely exciting. If you haven't looked into the details of mentorship programs that we've been running, they're extremely exciting. So I highly recommend checking it out. Lots of people participated. We get lots of positive feedback, and it takes an enormous number of people, an enormous amount of work to actually make it happen. So thank you to everybody for helping run the mentorship stuff. We have a great communications team, keeping everybody up to date, and we broadened the reach of ML4H notifications by a lot this year. And of course, we have a great fundraising team and some amazing sponsors. So thank you again to the sponsors for helping us put together this awesome event. Yeah, we were able to give away a lot of money for student travel and registration and paper awards, and also for some organizer travel. And then the whole proceedings is up on PMLR, thanks to the hard work of Stefan and Antonio. And again, thank you for the logistics team for actually making everything happen today. So they've been running around frantically and setting everything up yesterday and last night and this morning, and it takes a tremendous amount of work. So thank you again. And finally, so we have some post-conference details. Obviously, we want as much feedback as we possibly can so we can improve ML4H next year. There will be a post-conference email sent out right after the event, so please read it. Please fill out the feedback form and send us any email if you want to get involved in reviewing, organizing, or mentoring, or if you have any questions or concerns about the event. And also there's the other Ali-sponsored conference, Chill. It's happening in June in 2024 in New York City. So hopefully we'll see some folks there. So thanks again, everybody. Feel free to stay and continue conversations for a little bit if you want to, but I think some organizers will start walking over towards the social event area, and we'll also be starting to take stuff down. If you have a poster, please take it down. If you were awarded a paper award, please go out to the main area. We have these certificates, so you can take a look. Thanks again, everybody.